questions. And with that, it's my pleasure to introduce our first speaker, Dr. Scott Friedman, who is the Dean of Therapeutic Discovery and the Chief of the Division of Liver Diseases here at Mount Sinai. And he's going to be providing us the big picture, everything NASH and MASH that you want to know. So with that, Scott, please get us started on a great day.
Thank you, Mina. Well, it's a real honor to be part of this fantastic effort that's been organized primarily by Mina that celebrates in part the NASH Center of Excellence that Mina is leading. And this really gives us an opportunity to highlight the advances and the unmet needs in our field. I'm charged with the task of giving a large overview, so I'm going to touch on a lot of different areas that you will hear much more about by better experts than me in this specialized domains. So my hope is that you get excited about what you're going to learn from our other speakers after the next few minutes of talking. I have a number of conflicts. None of them are relevant to this talk today. So many of us know this, but let me start with the basics, and that is the nature of the disease. You're going to hear more about the new nomenclature from Dr. Ranella. So I'll just emphasize that there has been an agreement on a new nomenclature that's now metabolic metabolic dysfunction associated steatotic liver disease. This is a spectrum, as was NAFLD, where most patients with fat in their liver have plain fat. A subset, maybe 20 or 25%, progress to an inflammatory and fibrotic condition, which is the state in which we're really worried about the development of cirrhosis and cancer long-term, which can eventuate in a growing fraction of patients over time. You'll hear much more about hepatocellular carcinoma from an international expert, Dr. Villanueva, on our faculty. And one of the points I'm making, and he will probably emphasize again, is the risk of hepatocellular carcinoma in NASH, even when patients are not yet cirrhotic. And I'll say more about that in a minute. I'll also emphasize a little bit about the evolution of staging the disease. For at least a decade, the disease was staged by three pathologic features that you see listed here: steatosis, lobular inflammation, and ballooning. But in fact, none of these features actually correlate or predict outcomes. The only histologic feature thus far that has been tracked with outcomes over the long term is fibrosis. And so what we've seen over the last 5 years is a gradual shift away from trials that try to track the NAFLD activity score components and much more towards either complete abrogation or resolution of MASH or an improvement in fibrosis with no worsening of MASH. So you'll hear much more about that. But suffice to say that fibrosis is really the linchpin of predicting outcomes in this disease. So we also know, and this is really to emphasize, that unlike the liver diseases we've been used to treating, viral hepatitis primarily, and even autoimmune liver diseases, MASLD is really part of the metabolic syndrome, meaning it's a systemic disease. In some ways, we've been spoiled by the remarkable efficacy of antivirals. We now cure Hep C in almost all patients. We can suppress hepatitis B with just antivirals. Those days are over when it comes to MASLD, because this is a multi-system disease of which liver can play a prominent part. And that includes defects in the liver that regulate insulin resistance and lipids and other defects in the liver, which you'll hear much more about. But it's also a disease of the pancreas, and in particular, type 2 diabetes, as I'll show you, has a very high risk, or portends a very high risk of developing MASLD as well. In fact, type 2 diabetes is probably the strongest predictor of whether patients not only will develop the disease, but also whether they will have fibrosis that will advance. One very vexing part of this disease syndrome is that there are actually some patients who are not obese who have this disease, so-called lean MASH, which seems to be a bit more prevalent in Asia, particularly South Asia and the Far East. The reasons for that are unclear, and so we have a lot to learn, because a disease that we have traditionally linked with obesity can occur even in the absence of that obesity. It won't surprise you to hear that this is a widely prevalent disease. There's some recent data from Yanasi that underscore the remarkable prevalence of fat in the liver among patients throughout the world. So this is not just a European or a North American disease. The prevalence, in fact, is even higher in Latin America, in Middle East and North Africa, as well as the Far East and South Asia. And so this is a worldwide problem. And if you think about it, 30% of the world's population have some element of fat and perhaps more in their liver. That's an astounding healthcare burden that we are not really prepared to grapple with just yet. And in fact, as this survey also from Zubair Dionasi shows, the worldwide prevalence is increasing. So if you're looking at the different intervals between 1990 and 2006, then upwards to 2016 to 2019, it's obvious that there's a rising prevalence. And this is certainly true in the United States as well as Europe. But remember that I told you among the risk factors for patients who have the metabolic syndrome, among the risk factors that predispose or predict fibrosis or more advanced disease, diabetes is in a class of its own. This is a remarkable map showing the prevalence of MASLD among type 2 diabetics across the world. So if you look in the lower left-hand corner, the lowest is 41% of diabetics in Japan have MASLD. At the high end, almost 95% of patients with type 2 diabetes have MASLD in Turkey. The United States is somewhere in the middle. 68% of diabetics in this country are going to turn out to have either fat or MASH. And so it's incumbent upon us to not only recognize this, but also to educate the providers who are primarily taking care of our diabetic populations. Of course, that includes endocrinologists, general practitioners, primary care doctors. I think it's reasonable to require or expect that every patient with type 2 diabetes should be screened for MASLD or MASH. Just to underscore that, a prospective study done by Rohit Lumba and his group in San Diego enrolled just over 500 patients to assess prospectively to assess the prevalence of NAFLD or NASH, MASLD or MASH in their population based on non-invasive markers that included MRE and MR fat fraction and also transient elastography. Almost exactly 2/3 of their diabetics had what was then called NAFLD, now MASLD, 14% with advanced fibrosis, and 5.9% or 29 patients with cirrhosis, among whom 2 had a hepatocellular carcinoma and 1 had a gallbladder adenocarcinoma. So I really need to emphasize that the prevalence of diabetes in metabolic syndrome is a marked risk factor and must be noted with efforts to determine whether there's underlying liver disease. I also mentioned that the hepatocellular carcinomas that arise in MASLD have a unique feature, and that's underscored by the study here, in which in a VA population in Texas, 2/3 of the patients who developed hepatocellular carcinoma had cirrhosis, but that means 1/3 of the patients who presented with cancer did not yet have cirrhosis. And this has important implications because if our screening guidelines are restricted to those who have definitive cirrhosis, we are going to miss liver cancers. And in fact, that's been the experience, is that the cancers that typically arise in MASLD are larger and diagnosed later and therefore have a poorer outcome. And so I think most clinicians recognize that screening needs to be started before patients are cirrhotic with this disease, whereas in Hep C, Hep B, and these other etiologies, over 90% or almost 90% of patients are already cirrhotic at the time that their hepatocellular carcinoma is diagnosed. So this has at least a couple of implications. In NASH or MASH, there clearly are other factors beyond fibrosis alone that contribute to HCC. And what are these factors? Well, that's a lecture unto itself, but in short, there are a whole host of metabolic abnormalities associated with the metabolic syndrome, in particular higher levels of circulating IGF, among others, that may also predispose to cancer. And in fact, we know that obesity per se confers an increased risk of all cancers. And among these cancers, hepatocellular carcinoma has the highest rate of increase in patients who have this disease. And so we need to reframe our thinking not only about diagnosis, but also about treatment. Of course, the prevalence tends to track with the prevalence of MASLD, but note in particular the very high prevalence or incidence, sorry, of associated HCC in the Middle East and North Africa, particularly Egypt, and also in Mongolia, where there's a high prevalence of co-infection with HCV, HBV, Delta, as well as high rates of alcohol use disorder. And so this is, and as you learned from Augusto, this is the fastest rising cancer in our world. It's not the most prevalent, but hepatocellular carcinoma in particular, due to MASLD, is emerging as a major public health threat in its own right. So we need to learn a lot more. Now, I mentioned that there are probably unique factors that predispose to hepatocellular carcinoma and MASLD that are different from other etiologies of advanced liver disease. And this landmark paper by a consortium of investigators here and in Europe, including our own Josep Levet, underscored the fact that the response to therapy in MASLD patients who have HCC may be very different. So specifically, in this paper in Nature 2 years ago, they tracked the outcome of patients treated with the emerging checkpoint inhibitors for cancer and compared their outcomes based on whether they had MASLD or other etiologies. And this is both a discovery and a validation cohort. It's pretty clear here that if you look in blue, the patients who were treated with checkpoint inhibitors who had underlying MASLD had a poor outcome in both cohorts compared to those who had other etiologies, primarily viral hepatitis. And this, of course, suggests that there are different factors in the milieu of the advanced liver disease in MASLD, particularly different immunologic factors that may predispose to cancer and that may confer greater resistance to therapies. And in this particular article, the author speculated based on animal data that there may be NASH or MASH-related aberrant T-cell activation that leads to impaired immune surveillance. I can tell you that since that paper, there have been intense efforts, both in Dr. Lovett's lab and throughout the world, to identify the specific immunologic features of this cancer when it occurs in MASLD compared to other etiologies like hepatitis B and C, and that will ultimately influence the choice of therapies for HCC. We shouldn't lose track of the fact that as a systemic disease, the burden of MASLD is not just in end organ damage, but has a tremendous number of impacts on health-related quality of life and patient-reported outcomes. Again, from Zubair Yanasi in a recent study or recent review, he underscores the negative impact of the disease on physical and mental health, the high rates of comorbidity, including type 2 diabetes and obesity, very high symptom burden, not just liver related, but fatigue, anxiety, depression, sleep, cognition problems, and vague abdominal pain, all of which leads to deterioration of the quality of life as the disease progresses, which in turn contributes to a worsening quality of relationships, ability to work and perform daily activities. So this is a disease that not only affects organs, specific organs, including the liver, but also has profound impacts on the quality of life and the lifestyle of patients who suffer from it. And so we need to be mindful of that. And clinical trials are increasingly assessing whether treatments not only improve the liver, but whether they improve the health-related quality of life. Now, I mentioned to you fibrosis drives outcomes. If you remember, I showed you that the NAFLD activity score turns out by itself does not predict outcomes, whereas fibrosis does. This was not the first, but is by far the best prospective study that underscores the importance of fibrosis in determining the outcomes of this disease. It was organized by Arun Sanyal, published in the New England Journal 2 years ago, almost exactly, and relied on the work of the NASH Clinical Research Network of the NIDDK. And what the study entailed was following over 1,700 patients, starting with a liver biopsy at time 0 and tracking them and following up at 10 years to assess how those patients did over that 10 years based on their initial stage of fibrosis. F3 and F4, of course, being advanced fibrosis. And in fact, these more advanced patients had a much higher risk of death from any cause, a dramatic increased risk of hepatic decompensation events with with over a 50-fold hazard ratio among F4 patients. So clearly, fibrosis over time, particularly advanced fibrosis, has a dramatically high risk of decompensation that, of course, can lead to liver failure and potential need for transplant or death. And of course, hepatocellular carcinoma in this study also tracked with higher fibrosis rates as well. So I think this is the most convincing data that if we're going to make an impact on the disease by treating either by medications or other means, we need to see that fibrosis at least stops in its tracks if it's not already cirrhotic, or better yet, that fibrosis regresses with successful treatment. And we're getting closer, as you'll learn about today. I also alluded to biopsy and the staging using a semi-quantitative subjective scoring system, but we have technologies that are far more powerful in extracting information from liver biopsies. This is one of, I think, 4 platforms now that are being developed and advanced rapidly to quantify features of liver biopsy to much greater detail in order to make a much more granular or nuanced assessment of disease stage and disease improvement or worsening. So what you're looking at here is data from a liver biopsy generated by PharmaNest, which is one of those different companies. Here you see a section of the liver in the upper left-hand corner that's now enlarged, and with the help of digital pathology, every element in this biopsy can be colorized and quantified automatically through a computer or digital imaging. And all of these different features of the fibrosis in particular, as well as other features, can be quantified to an exquisite extent so that we can get a much more detailed picture of what's going on histologically. The FDA has indicated they're open to the idea of these non-invasive markers, but will require that these markers be shown to be as good or better in predicting outcomes. I think that's a low bar, given how much information is extracted from a digital pathology image like this, or like the ones that are generated by other companies, including PathAI and HistoIndex and BioSelv. So as some of you may know, my interest has been the pathogenesis of fibrosis or scarring. We started this work almost 40 years ago at UCSF when I was a fellow in the laboratory at Monte Bissell. And we ultimately set upon to isolate and describe cells that are shown here in blue, the hepatic stellate cells, previously called lipocytes, fat-storing cells, parasinusoidal cells. We now all call them stellate cells, and they are a normal cell in the liver. But when the liver becomes injured, fibrosis advances because these cells are replicating and becoming more fibrogenic, and they're leading to deterioration in this subendothelial space of DISA that impacts on the ability of hepatocytes and endothelial cells to do their job. So fibrosis accumulates, leading to cellular dysfunction. The good news is everything you see here in this drawing is actually reversible. And so this is the goal of therapies for MASLD or for any chronic liver disease, is to turn off the scarring and to restore the architecture to normal. Stellate cells have become a fascinating topic, and dozens of laboratories around the world are pursuing a clear understanding of these cells and have unearthed a plethora of targets that could potentially attenuate fibrogenesis. I'm not going to review this, but this is from a review article I wrote with a visiting scientist from Japan some years ago that illustrates that there are receptors, intracellular mediators like oxidative stress, as well as a number of nuclear events that all contribute to stellate cell activation and fibrogenesis, and virtually all of which represent potential therapeutic targets as we try to develop treatments for this disease. But we shouldn't ignore other elements that also contribute to the disease. And I'm fascinated by the potential of the microbiome to confer disease risk. This is one such study that underscores the risk of microbiome, or the contribution of microbiome to liver steatosis, because human gut microbiota from obese patients can induce liver steatosis when transferred to normal mice on a normal diet. So that's remarkable. What's really also interesting about this study is if the patients who had liver steatosis lost weight and attenuated their disease, their microbiomes no longer could confer NASH in germ-free mice. And this is really an interesting concept because the evolution of our gut microbiomes over the past 50 years, in part due to the pervasiveness of antibiotics, among other reasons, that changing microbiome could explain in part why our population is getting more and more obese and developing more and more liver disease. Because after all, there are genetic contributions, but they have been present in our genomes for tens of thousands of years. So something must have changed more recently that drives the disease in the past 50 years that wasn't present earlier. The microbiome may be one of those stimuli. We also know that the family history can be quite important, and this is a study of last year from Rohit Lumba's group looking at the risk of advanced fibrosis among first-degree relatives. And what you can see is whereas relatives of patients who have no MASLD have a very low risk of MASLD, in the red bars, what you can see is that whether in the UCSD or Helsinki cohort, there's a higher and a significantly higher risk of MASLD among first-degree relatives of patients who already have advanced fibrosis. And that's also true if one tracks the prevalence of advanced fibrosis instead of the prevalence of MASLD. Again, if your family member, first-degree relatives have advanced fibrosis, there's a substantial up to 15.6% risk that the patient, him or herself, will also have advanced fibrosis. Now, some of that could reflect the fact that first-degree relatives typically live together and share their microbiomes. And so this could reflect in part the effect of the microbiome that's shared among first-degree relatives. But it certainly also reflects the contribution of different genetic variants that we'll hear more about from Dr. Jamie Chu. These variants have been discovered through GWAS studies, and they can include variants in genes related to inflammation, fibrogenesis. In particular, most of the genetic variants that have been uncovered regulate lipid droplet remodeling, and there's been more that's discovered since this slide was generated by Eric Tripot several years ago. There are also defects or variants in glucose metabolism, as well as lipid catabolism, and finally, oxidative stress. So the genetic contributions are very clear, but we don't know yet how to use that information to either predict risk or change the diagnosis. On the other hand, some of these variants are turning out to be very attractive therapeutic targets. For example, efforts to turn off HSD17B13 using gene therapy look very promising because they replicate the effect of a non-coding or a truncation variant that inactivates the disease and protects patients from MASLD. So we need to learn how to combine these many different inputs that include genetics, microbiome, other environmental factors that could include pollution, particulate matter, and others that all converge to create this disease. If we start to think about how we're going to develop therapeutic targets, we look to the sequence of events that starts with fat accumulation in hepatocytes, engages inflammatory signaling, and also elicits soluble factors from the fatty hepatocyte, in particular, generally called lipotoxicity, that converge on the activated stellate cell, as well as changes in the epigenome that can program stellate cells to become more fibrogenic. So this is a template upon which we can layer potential therapies. Will therapies work? Well, we know that bariatric surgery can have elicit a significant improvement in the disease. These are data from Philippe Mathurin and his group in Lille, France, showing that the resolution of NASH can be affected in over 90% of patients if the weight loss exceeds 10 kilograms per meter square. And with that, over a 5-year period after bariatric surgery, fibrosis can improve. And so you can see here the fraction of patients at 5 years who have advanced fibrosis is far less than the prevalence of fibrosis prior to bariatric surgery. But there is some data to suggest that cirrhosis may not be reversible. And this is a study from Vlad Rațiu and his team in France that show that in a follow-up study following bariatric surgery, whereas 10 patients had cirrhosis at baseline, 7 remained cirrhotic in follow-up several years later. So we need to learn what is the point of no return and what prevents cirrhosis from being reversible, even if therapy extreme as bariatric surgery is instituted. And so to return to that template of therapies, you can hear a lot more about this from others. So I'll just emphasize that we can target the fat, we can target the insulin resistance or inflammation, we can target the stellate cell. All of these are being developed, but of course, none of them have really reached proof of principle yet in phase 3 trials, except for thyroid hormone beta agonism, which you'll hear more about later today. Finally, we need to be thinking about cirrhosis as a very different disease and has many stages compared to F1 to F3. And this is from a review that several of us wrote quite a while ago that underscored the fact that cirrhosis is more than a single stage. And at some point, patients develop portal hypertension, and that's followed by decompensation. So if we're to develop therapies for cirrhosis, what would be the best point? I would argue that certainly patients need to remain compensated if we're going to have any hope of instituting effective antifibrotic therapy. We've also learned more about the changes that the liver undergoes during progressive disease. This is from a paper we published earlier this year by my faculty colleague, Sammy Wang, that shows that if you use a specialized imaging that detects only stellate cells in progressive NASH in a mouse, there's an increased number of cell-cell contacts that underlie autocrine signaling. The point of this is that the structure and interactions of stellate cells change as cirrhosis develops, and this will unearth a whole different list of therapeutic targets. Suffice it to say that I think this indicates that the treatment for early NASH, where there's fat and inflammation and some fibrosis, may need to be different than the treatment for patients who already have cirrhosis and have lost the fat and inflammation. So with that, let me just illustrate some of the challenges that we're confronting. One obvious question is, why do only a fraction of patients with liver fat develop MASH? Could it be genetics, the microbiome, diabetes, lipotoxicity, or environmental exposures, or all of the above? How can we diagnose this disease non-invasively, and who should we be screening, particularly as we're on the cusp of having hopefully an improved therapy for this disease? Certainly, you're going to hear much more about diabetics, pregnant women from Dr. Kushner, and perhaps other populations like HIV from Dr. Bansal. We know non-invasive biomarkers are the future, but we're not there yet, and the FDA has still required liver biopsy to approve drugs for this disease. And we don't know with certainty which biomarkers or combinations of biomarkers are ultimately going to be the most effective in screening and diagnosing and staging the disease. And finally, and perhaps most importantly, when are we going to have a treatment? And what will be the impact of all these weight loss drugs? Is cirrhosis reversible? I've illustrated that it may be, but not in all patients. And very importantly, if and when drugs are approved, how do we know if patients are responding? No one is suggesting we'll continue to do liver biopsies in those patients, and yet, except for example, the thyroid hormone beta agonist that's on the verge of being approved will only improve disease in about 25% of patients. So how do we know which patients are in that 25% who are improving and which patients are not improving and may need other therapies instead? So we have big challenges ahead. On the other hand, we've made enormous progress in a short amount of time. And the symposium today will highlight many of these challenges and some of the hope on the horizon to improve the outlook for patients with this illness. So with that, I'll close and take a few questions. Thank you.
Great. Thanks so much, Scott. That was wonderful. We do have one question from Dr. Calusi. I understand that we could reverse the process of fibrosis, but once there's actually scar laid down or fibrosis, are you saying that that also can be reversed?
Yes. In short, to a certain extent, fibrosis can be reversed, even in early cirrhosis. Remarkably, we know very little about the mechanisms underlying that. We don't know which enzymes are breaking down that scar. We don't know where they're coming from. We don't know how they're regulated. And of course, if we could get a handle on how the liver breaks down scar when the disease is improved, that could translate into therapies. And the best example is not necessarily MASLD, but actually viral hepatitis. There's stunning reversal of cirrhosis in some patients treated effectively for hepatitis B or C. So we know the liver has an endogenous capacity to literally chew up scar. We don't know what regulates it yet.
Great. Thank you so much. And with that, we can move on to our next speaker.
So I'm going to take over the chairing duties for the remainder of the session, and it gives me enormous pleasure and pride to introduce Dr. Maru Ranella from the University of Chicago, who has been at the forefront of many components of understanding the disease, and most recently, it's led the charge to standardize the nomenclature for this disease. Maru, we look forward to your comments.
First of all,
Yes.
thank you very much for the invitation. And it's always difficult to follow Scott. So thanks, Mina, for doing that. But I really appreciate the invitation. And what I've been asked to speak about is just a quick introduction or overview of the nomenclature changes and then the potential impact on patients, industry, providers, and regulatory agencies. So these are my disclosures, which do not pertain to this talk. And I thought I'd start with this because I think that we may forget that the nomenclature of NAFLD and NASH has really been evolving for quite some time. In 1980, Jürgen Ludwig, a pathologist from the Mayo Clinic, initially described steatohepatitis in a patient who did not drink any alcohol despite histologically really appearing to look like alcohol-related steatohepatitis. And then 20 years after that, in 1999, Marioni described the spectrum of disease that we then referred to as NAFLD. And now, 20 years later, we find ourselves in the same place revisiting nomenclature. And this was initially sparked by a paper in 2020 that introduced a new terminology called MASLD that also, along with it, it had a change in diagnosis, which included at least 2 metabolic features and did not set a ceiling on alcohol. And this created issues due to changes in the natural history of the disease. So nomenclature is a complex thing, and there are specific guidelines set forward by the WHO recognizing the importance and impact of nomenclature. And really, this is a process that can impact patients very significantly, societies, and with respect to societal perception, and really needs to be informed by medical experts and then taken up by policyholders. So our process was a fairly extensive process led by me on the ASLD side and Philip Newsom on the EASL side. And we put together a panel of 264 nominees from around the world representing 56 countries in order to conduct a Delphi process to reach a consensus over what was quite a divisive and contentious issue at that time. So one of the things we debated very heatedly was what consensus looked like. What was the right consensus? Do we want 90%? Was 51% enough? And so we put a lot of thought into this. And I kind of wanted to go through just some examples in history, because I do think that kind of helps set the stage a little bit. So I think importantly, consensus does not mean unanimity. A good example of that is in 1950, where the UN Security Council, and still to this day, requires unanimity to pass a resolution, which can be quite stifling. So the Soviet Union was not present during this particular meeting, and because of that, the other countries voted unanimously to enter the Korean War, and whether or not you can argue whether that was meaningful or intentional or not, they never missed another vote after that. So our debate over nomenclature has been very politicized and very polarizing, and a perfect example of how this can be very damaging was with the COVID pandemic, where we had implementations of mask mandates that were clearly the scientifically based. We knew that mandates reduce transmission of disease. However, it was not uptaken in a uniform manner, and clearly those mandates fell along political lines, which doesn't make logical sense. And then finally, we need policy to be able to drive action. If we get, believe it or not, Reynolds, the biggest tobacco company, was actually sponsoring medical meetings and was advertising in medical journals, including JAMA. And it wasn't until 1964, at which point about 40% of the US adult population smoked, that the Surgeon General came out with a report that smoking caused lung cancer and probably other things. And from that point forward, legislation came through and smoking dropped dramatically. So where we ended with the consensus nomenclature is here, and conceptually, the differences that are worth noting are that we the consensus was for the supermajority was reached that steatotic liver disease, which is the umbrella term, would then encompass not only the replacement term for NAFLD, which was MASLD, metabolic dysfunction associated steatotic liver disease, and within it MASH, but also included an overlap category between those that met criteria for MASLD but drank more than the allowable limit up to a certain point. And that's just something that we had not done and is a population that is common and really needs further study. So I think this opened a lot of opportunities for us. So changing the name is one thing, but the difficult part is implementation. And there are multiple implications of nomenclature change for a disease that afflicts a very large portion of the world's population. So from a clinical care perspective, disseminating nomenclature change is a big task and a critical task. People need to adjust their narrative of how they speak to patients. There's, of course, but the potential for an impact on the interpretation of existing data and disease awareness, and especially patients, because it may detract from their understanding of the disease if they were familiar with one term and not yet familiar with another. And then, of course, there are potential implications for clinical trial design, industry, and regulators. So effective implementation requires multiple different facets, and I will walk you through what we've been doing and what we intend to do. So from an awareness and implementation perspective on the medical education side, we've really seen really nice uptake and use across multiple platforms and liver meetings across the globe, as well as individual symposia such as this and other society meetings. What we still need to do is reach out to the American Board of Internal Medicine and work on changing medical school curricula to help start this from the ground up. And we've received now about 75 endorsements from other societies. Use in publications has also been increasing, and I'll show you an example of that. And then use in practice, again, that's going to be a much more grassroots effort, which we are, of course, engaging in, but that will take time. So we've seen a very significant increase in scientific publications in July of 2023, about a month after, not quite a month after we'd released this at the end of June at the EASL meeting. You see that there's already been very significant increase in publications. And just a couple of days ago, there were 77 papers using MASLD. So from the ASLD side, we've provided lots of decision support tools to help people understand how to implement the disease in their practice, how to reach the diagnosis, and then provide, as you can see here, the cardiometabolic criteria, which were based on accepted criteria as outlined by Alberti et al. In the Circulation paper in 2009. So stigma was an important piece of this, and it was something that we discussed significantly. There were issues from a stigmatization standpoint with both non-alcoholic and fatty. 66% of our respondents felt that fatty was stigmatizing, and 60% felt that non-alcoholic was stigmatizing. So of course, stigma varies between individuals, between cultures and languages. And when possible, it's important to avoid the use of stigmatizing language. And for that reason, we chose steatotic liver disease as opposed to fatty liver disease for the overarching term. There are several papers that are forthcoming on stigma in this population, at least one or two of which were going to be presented at the ASL meeting in November. So with respect to impact on patients, it's the advantages of this are that it does use non-stigmatizing language. It allows for more seamless discussion of the root cause or underpinnings of the disease. It offers a diagnostic category for those who meet criteria for MASLD and ingest alcohol above the allowable limit, but not enough to be considered pure alcohol-related liver disease. The disadvantages are, of course, that this constitutes medicalization of the lexicon, and there's less familiarity with the new terms. So with respect to practical application in patient care, we and several others are working on webinars to help translate and discuss the new nomenclature and how to discuss it with patients. We're in active partnership with numerous patient advocacy organizations, including American Liver Foundation, Fatty Liver Foundation, Fatty Liver Alliance, and others to increase awareness and then assist in implementation. And there's, of course, ongoing conversation with patients and other patient groups. So important factors to consider regarding clinical trial design, and I think that with especially supported by several papers that have now come out, we do not expect there would be any impact on endpoints. There really should be no impact on endpoints. There's no change in the definition of steatohepatitis or disease staging, so that really is a non-issue. With respect to biomarker development, we've had some preliminary analyses with biomarker consortia such as the Litmus Consortia, where 99% of the patients meet criteria using the MASLD diagnosis that are in their database. There are also other papers that have been published, one by Vlad Ratziu and his group, also demonstrating 98.4 overlap in his population, and in NHANES, again, very high overlap as well. So there really should be no impact either on biomarker qualification or interpretation of existing data. And for all intents and purposes, the two terms, MASLD and NAFLD, can be used interchangeably, and NASH and MASH can be used interchangeably. And then importantly, this does open new opportunities to study the overlap with ALD, and there's already significant interest in this in the pharma industry. So importantly, many of us were at the FDA meeting in September on nomenclature, not nomenclature, on NITs in the field. And you can see here in a presentation by George McCarr that he started out the presentation stating just that the terms could be used interchangeably. Now, there is, of course, ongoing engagement with FDA and EMA through the Liver Forum, and we are hopeful that we will come together. I think that the main sticking point is going to be until we are able to achieve ICD coding. It's going to be a little bit challenging for the FDA, I think, to openly have a statement, but I believe they're working on something. So with respect to higher level adoption, again, we really need to focus on regulators. We need to continue to have discussions with industry. And then really the most difficult part of this is going to be in billing and coding implementation with respect to engagement and ongoing engagement with WHO and engagement with CMS, which we are actively pursuing. So importantly, there's broad implementation across cultures. The ASLD website has been translated into Spanish and French, and Portuguese, Mandarin, and Arabic are also in process. EASL through the European Liver Society also has broadly implemented, in the Latin American Society, and several other societies are using the nomenclature as well. So one of the efforts to increase the global sort of unity around this topic of increasing awareness and unifying around nomenclature took place at Wilton Park, where we had a 3-day think tank that included hepatologists, gastroenterologists, obesity specialists, family medicine, policy experts, epidemiologists to discuss how we might reach a place where we all have a unified response. And this has led to significant collaboration, which has been published. Actually, there have been several papers published. This same group also participated in an event at the World Health Assembly, in an event organized by EASL, which was really a very, I think, important and transformative event for us to be able to discuss directly with the WHO issues surrounding awareness and nomenclature as well, which they were aware of based on communication that we had already had with them. But we had several health ministers from from areas where there's very high disease prevalence, and there seemed to be agreement that we needed to tackle this together and ultimately have this recognized as a non-communicable disease within the WHO, and eventually change the next round of ICD coding. So as far as actions, we'll continue to hold stakeholder meetings to determine if determine the challenges of implementation and needs. And this is with patient groups, CDC, CMS, WHO, NIH, FDA, and pharma. From a hepatology perspective, we are updating the guidelines or the guidance to have a living guidelines on MASLD online. We have the decision tree and other infographics, as I mentioned, and PowerPoint presentations that can be downloaded and used for sharing. The campaign to increase awareness and adoption. Again, it's important that we coordinate between societies to speak one voice. And we are seeing increased presence in endocrine, cardiology, and primary care meetings. And collaborations with industry, I think, are going to be critical at this time, because there are increased efforts that are being put forward to identify patients at risk because of the impending emerging therapeutics, is really well aligned with our goals at this time. And we can leverage that and work together to increase awareness and spread the word. And again, we have work to do from a learning medical school curricula standpoint to further implementation. So looking at a Gardner plot, which really can apply to lots of things, but here I think that we've been through the whole spectrum with this particular nomenclature process. I really do think we're starting to see the light, and we are going to see significant productivity to follow, but we have work yet to do. And with that, I'd like to thank you for inviting me to give this talk. I'd like to thank Phil Newsom, who was instrumental, the ASLD governing board and staff, the SLD task force, of which Mina Bansal and Maza Nuruddin and Naeem El-Khoury are very important and partners with me as well, leadership of EASL and Ale, and I'll be happy to take any questions. Thank you.
That was great, Maru. Very clear and quite a heroic effort. It was insightful. We have two terrific questions that I'll try to merge. One is from a primary care physician who asks, how do you explain the diagnosis of the disease to patients with low health literacy? And following on that, another questioner asks, what has been your experience with explaining the new nomenclature to patients? Steatosis does not seem to be a word that patients are familiar with, and I usually end up explaining that there is fat in the liver. Any strategies how to address these issues?
Yeah, so I don't avoid talking about fat in the liver. I think that's a concept that's fairly easy for patients to understand. And I don't think there's anything wrong with using that. I think where the stigma comes in is with, discussing and telling family members and friends what they have. So that I don't avoid using fat. That's an understandable term. I try to explain the why fat accumulates in the liver, which has to do with an abnormal way that their body processes nutrients and food, and this is sort of driven by usually accumulation of fat in the abdomen, then fuels the liver. This is to somebody who is a fairly non-sophisticated person. You could be a little bit more detailed than somebody who's got higher health literacy, but I don't not use fat because I do think that's easy to understand. I think that their takeaway, if they ask what the name of their disease is, it's MASLD. That doesn't really. I sort of look at it like there are many acronyms that we use that we don't even know what they mean anymore. BMW, nobody talks about what that acronym actually means, or Xerox copy, or PDF or M&Ms. So I think that eventually, with using the term enough, it'll become commonplace. But using the term fat in the liver, I don't think is problematic.
Okay, very thoughtful answer. Thank you again, Maru. I think we're going to move on to our next speaker. I see in the Hollywood Squares lineup, Dr. Manala Delmalik, who's a professor of medicine at the Mayo Clinic, and her talk is entitled "Cracking the Code: Making the Diagnosis, Risk Stratification, and Prognosis Prediction in MASLD." Great to have you, Manala. Good morning.
Thank you, Dr. Friedman and Dr. Vansel. I can't thank the organizers enough for the invitation to be here. So I've been asked to talk about cracking the code and making the diagnosis, risk stratification, and prognostic prediction in MASLD and MASH. I do a lot of clinical research on the landscape, but I have no direct conflicts with this presentation. So in the next 15 minutes or so, we're going to highlight and review the diagnostic criteria and evaluation of patients with presumed MASLD and MASH, to discuss the approaches to risk stratification in accordance with the practice guidelines, and to discuss the recent evidence on how to use these non-invasive markers for risk prognostication prediction of outcomes in MASLD and MASH. Now, I know many of you have seen the recent guidances from the ASLD that were led by Maru Ranella. And the diagnostic criteria, I think, is very nicely spelled out in this guidance paper, and really is detailed both for adults and for pediatric cohorts, and emphasizes and underscores the element of metabolism. At least one of 5 of the metabolic criteria necessary to qualify a patient for metabolic dysfunction associated steatotic liver disease. So the diagnostic criteria is under the umbrella of steatotic liver disease, and a patient has to have at least one cardiometabolic risk factor. And if they do, and if there are no other causes for steatosis, they have otherwise met the criteria for MASLD. And if there's overlap, of course, with social alcohol consumption, ALD. In the absence of metabolic risk factors, the patient could be qualified as having an alternative etiology for liver disease, such as drug-induced. But if they do not yet have metabolic risk factors, that's not to say that they couldn't develop them down the road, but they would otherwise be qualified as cryptogenic. In such patients, we should have a heightened awareness of the potential for prediabetes or family history of metabolic risk or liver disease, because with time they could then move out of the bucket of cryptogenic into MASLD. So the emphasis is on metabolism. Now, in order to make a diagnosis, one has to have heightened recognition of these metabolic risk factors, and they do include truncal obesity and overweight obese status, insulin resistance, hyperlipidemia, particularly hypertriglyceridemia, low HDL, hypothyroidism, and even other conditions that fuel metabolic syndrome, such as polycystic ovarian syndrome or obstructive sleep apnea. And why is this recognition so important? Because, as you could see here, obese status confirms anywhere between a 50 to a 90% of these patients may have MASLD, and likewise up to 70% of patients with type 2 diabetes. So recognition and association with metabolism is important. However, this does remain yet a condition of exclusion of alternative causes. And here I highlight for people just a table of how many alternative causes can cause steatotic liver disease, and to always be aware to look at medications to ensure no presence of infections such as hepatitis C, or in a young individual, even consideration of alternative diagnosis such as celiac or Wilson's disease. So the awareness of other causes of steatosis is important. Now, how do these patients present? It's important to recognize that they're not going to come in complaining about fatty liver disease or steatotic liver disease. The majority of patients are asymptomatic. Maybe somebody may complain of right upper quadrant discomfort. Liver aminotransferases can be completely normal, but if they are abnormal, they're usually less than a threshold of 5 times the upper limits of normal, with the ALT higher than the AST, unless there's the presence of cirrhosis. And 75% of patients may have a completely normal ALT and AST. And it's important that we emphasize to our primary care physicians what a true normal ALT is. It's less than 20 for women and less than 30 for men. And so an ALT of 40 is not really normal, or even 50. The alkaline phosphatase and the GGT may be slightly abnormal, but are usually less than 3 times the upper limits of normal for a lab. And rarely, alkaline phosphatase may be increased with benign steatosis alone in the absence of steatohepatitis in the presence. But on average, liver synthetic function is well preserved unless patients have advanced cirrhosis, and that's important to recognize. The association with metabolic syndrome, but don't be set off when we see abnormal ferritins, because they can be elevated in patients and up to 30% of patients. And there's not necessarily a need to check genetic testing for hemochromatosis unless you're dealing with a high ferritin above 1,000. And it's also not uncommon to find low titer autoimmune markers in trying to establish a diagnosis, but of course, one may need to consider the exclusion of autoimmune hepatitis. Here are some other conditions that are associated with steatotic liver disease, and they should be put in the context of the appropriate clinical scenario, such as the rare young patient with significant hypertriglyceridemia, lipidemia, and hepatosplenomegaly may be considered for lysosomal acid lipase. That very young patient with neuropsychiatric symptoms and a low alk phos or low ceruloplasmin should be considered for Wilson's disease. Or that iron deficiency anemia patient with low vitamin D and diarrhea, diagnosis of celiac should come to mind in testing. So establishing the diagnosis of NAFLD and NASH means putting into context with understanding risk factors for steatosis and exclusionary diagnosis. And just to point out here, here's a normal ultrasound on the left upper side of the screen. And on ultrasound, steatotic liver becomes bright and echogenic. However, on a CT scan, a steatotic liver becomes hypodense and less echogenic. On the bottom panel here, you'll see the classic histologic features. If a patient were to undergo liver biopsy, here's stored triglyceride. It almost looks like Swiss cheese in the liver. But upon establishment of necroinflammation, one can see this classic chicken wire fibrosis and the onerous ballooned hepatocyte, which confirms a definite diagnosis of steatohepatitis and classic lobular inflammation. And it's important because the establishment of steatohepatitis does not have a good surrogate biomarker, and as of yet is still a histologic diagnosis. Now, the prevalence and what's important is we really don't want to miss those patients who have advanced hepatic fibrosis and cirrhosis, and to keep in mind that there are high-risk populations, particularly those patients with type 2 diabetes or medically complicated obesity are high risk for advanced hepatic fibrosis. And even moderate social alcohol use confirms an added cofactor for fibrosis progression, as well as patients who have a first-degree family member who's known to have cirrhosis of any etiology, or definitely known to have cirrhosis or NAFLD and NASH. So genetic predisposition, and there are various genes, PNPLA3 being a predominant one for conferring fibrotic risk. So just to emphasize that liver enzymes do not need to be elevated in the context of establishing a diagnosis for MASLD or MASH in a cohort of biopsy-proven patients. over 200 were retrospectively analyzed. There was no difference in the rate of advanced hepatic fibrosis between somebody who had a normal ALT and somebody who had an elevated ALT. Absolutely none. And significantly lower percentage of normal ALT group had NASH compared to those that had elevated ALT. And 37% of patients had a normal ALT who had NASH with advanced hepatic fibrosis. So do not use this as a standalone diagnostic when trying to establish the diagnosis. That brings into place the armamentarium of non-invasive tests for risk stratification. And I know many of my colleagues will go into depth about these tests in later talks. So I'm just going to highlight that there are blood-based markers that are simple that one can look at. And I pay particular attention to platelet counts. And when those are less than 150, that could suggest the presence of advanced hepatic fibrosis. However, these simple clinical serum tests can be put into algorithms that are available on your iPhone that can confer a calculator-based risk assessment, particularly the FIB-4 score. And likewise, there are blood-based biomarkers such as the ELF score, which looks at specific circulating biomarkers of fibrosis. And we also have imaging-based biomarkers. The one most people are familiar with is FibroScan or vibration-controlled transient elastography. And of course, once we get into imaging-based biomarkers, particularly MR elastography, not only does cost go up, but availability can drop. So the algorithms and the guidances were built around access and availability and the ability to render point of care risk stratification. And just to point out to you that the FIB-4 score performs exceptionally well and has been broadly validated with an area under the receiver operating curve of 0.9 for advanced hepatic fibrosis, and likely a proprietary serum-based marker of ELF score also performs very well and has been broadly validated, so it is used more in clinical practice. This is just a highlight about the variances of the imaging-based biomarkers that can use to risk stratify. These biomarkers and imaging also should be used more for their negative predictive value because they're very, very good at excluding those patients that don't have advanced hepatic fibrosis, as opposed to including them. But as you can see here, excellent performance for advanced hepatic fibrosis, particularly. There is a failure rate more with operator assessments with transient elastography and potential confounders, but if accessible in your practice is an added concordant or sequential test that can be used in your diagnosis. So when do I consider a liver biopsy? If there's a compelling etiology that an alternative cause for liver disease could exist, or there's the presence of maybe a coexisting chronic liver disease, such as autoimmune hepatitis. When I consider a liver biopsy prior to committing to a patient to long-term liver-directed pharmacotherapies. Currently, it's in the context of clinical trials, or when I get discordant interpretations of biomarkers and I'm really trying to get at the heart of whether a patient has clinically significant NASH with fibrosis, or if I'm trying to, with certainty, ascertain the presence or absence of advanced hepatic fibrosis in the absence of other clear clinical markers. So here are the algorithms putting it all together in diagnosis. So if you have a patient with metabolic risk factors, ascertaining and performing clinical evaluation to exclude other causes, taking a look at liver aminotransferases, and certainly if elevated, performing the FIB-4, but even if not elevating, risk stratifying patients with metabolic risk factors. If that FIB-4 score is less than 1.3 and there's no metabolic risk factors, that patient can be confidently assessed every 1 to 2 years and re-risk stratified. If a patient has diabetes and metabolic risk factors, then following it up with a second surrogate, whether it be ELF or VCTE or MRE, and if low risk, following them, but if intermediate or high risk, going into an approach where a patient can be referred to a specialist, considered for a liver biopsy, and certainly if they have features or of advanced hepatic fibrosis, not losing sight of cirrhosis-based management, screening, and surveillance for hepatocellular carcinoma. And when we take a look at the clinical outcomes, it's all based on fibrosis as the primary predictor for both morbidity and mortality, with that risk increasing at patients who had fibrosis stage 2 or higher. So, fibrosis markers are really what define outcomes and predictions. And in a meta-analysis that was performed using also histology that evaluated fibrosis, VCTE, FIB4, the primary endpoint was the occurrence of liver-related and all-cause deaths, decompensation, liver cancer, or change in MELD score. And what we're seeing is that those patients who had significantly higher stages of fibrosis or who exceed these NIT non-invasive thresholds are at risk for disease progression. So patients with fibrosis stage 3 incur a hazard ratio of almost 3. Those with a fibrosis stage of 4 or higher, tenfold higher risk for liver-specific outcomes. So fibrosis drives it, and yes, these measures and predictors can also be ascertained using non-invasive markers, and we see the same with cirrhosis outcomes. So a VCTE of greater than 20 kilopascals can predict the presence and complications of portal hypertension. And so what we're seeing here is that FIB4, for example, can perform just as well as liver biopsy in predicting survival and predicting change over time as a predictive biomarker. So a rising FIB4 over time could correlate to that of histology in predicting clinical outcomes. We're also seeing the same for the use of ELF score. So at baseline, an ELF score that is less than 9.8, for example, these patients might have less risk of liver-related outcomes. But if the ELF score is greater than 9.8, these patients are at higher risk for a liver-related outcome over time. And certainly change in ELF score over time has also been demonstrated to be a predictor of progression to cirrhosis. We're also seeing the same with changes in transient elastography that can predict survival as well as be concordant to complications of liver disease as histology would be. And recently there's been publications that MR elastography and a change of 1 kilopascal in liver stiffness incurs a 3-fold higher risk of developing cirrhosis in the future. And in patients with cirrhosis, a 1 kPa increase in liver stiffness incurs a 32% higher probability of developing decompensation and death. So these biomarkers can be predictive of prognosis. And this again shows it in a slightly different light, that the probability of progression to cirrhosis or the probability of hepatic decompensation can correlate to changes in liver stiffness even by MR elastography. So the take-home points: we certainly need heightened awareness in evaluating and diagnosing patients with metabolic risk, that patients with diabetes, complicated obesity, concurrent alcohol use, and a family history of cirrhosis are at increased risk for advanced hepatic fibrosis. Non-invasive tests are important in risk stratification and exceptional for excluding those patients without significant fibrosis, but also lend algorithms by which to define the at-risk patient with advanced hepatic fibrosis. And both baseline thresholds and changes in these NITs can be predictive of future liver-related and survival-related events, and appear to be comparable to fibrosis, but data is evolving regarding the role of these NITs in prognostic prediction of clinically meaningful outcomes. And with that, I thank you.
Thank you, Manal. Very concise and informative. And we have a question that I think really gets to the heart of the challenges using these non-invasives. Shannon Calusi asks, I often get different results when I use the FIB4 and the FibroScan together. What is your opinion? Or I guess, how do you reconcile that, or what do you do to clarify?
Yeah, so when you get completely discordant results, I think it's important to look at the threshold of results. If your FIB4 is really quite low and your FibroScan is really quite high, that probably is a patient that either needs another surrogate or consideration of a referral and a biopsy. If they're both in the intermediate range, that again might be somebody who needs a liver biopsy to clarify. But I think one has to put with what's the means to the end. Are we trying to stratify those that have cirrhosis, or are we trying to bridge them to clinical trials and pharmacotherapies? Because I would argue that patients with the existing evidence can be followed, and that same patient can be brought back in a year and reassessed. But certainly those patients that have very high clinical risk factors, diabetes, age over 50, family history, I think I would consider for referral and biopsy.
Would you biopsy even if there's no prospect for a clinical trial to be enrolled? We try to restrict, if as long as assuming the diagnosis is not in doubt, we try to hold off biopsies as best we can in the event that the trial.
Yeah, I would agree. I think the non-invasive tests, especially when coupled with imaging and clinical predictors, are very good for telling us who has cirrhosis or advanced cirrhosis. Even just looking at a platelet count when you couple it, if it was less than 50, and those patients I will treat empirically and monitor with the assumption that they have advanced fibrosis. The role of a biopsy, I think, is going to play more of a role in liver-directed therapies for patients with NASH until we find a surrogate for that.
On the threshold of actionable information, we can do something with that. But I do think your point about longitudinal assessment is very important. Check the patient again in 3 or 6 months, and maybe that'll give you more clarity. I think we have one last question. When do you start surveying for HCC in the disease?
I start surveying a patient for HCC in the context of advanced hepatic fibrosis, fibrosis stage 3 or 4, but definitely for 4. And certainly when the platelet count becomes less than 150, I will start surveilling because that would suggest early hypersplenism and portal hypertension.
Okay. Manal, thank you again. I hope you can join us later. We're really pleased and honored you joined us this morning.
Thank you again for the invitation. It was a pleasure to be here.
So we'll move on now to our next speaker, Dr. Andrea Branch, a professor of medicine here at Mount Sinai in the Division of Liver Diseases, whose task is to review cardiometabolic risk factors in fibrosis and MASLD MASH. And, we're looking forward to this, Andrea. I know it's a great talk.
Okay, well, it's great to be here. I really thank the previous speakers for the clarity that they've given to the discussion of cardiometabolic risk factors, which are part of the case definition of MASLD. And what I'd like to talk about today is how these risk factors relate to liver fibrosis in particular and to other important health outcomes such as all-cause mortality and cancers, and how the relationship between cardiometabolic risk factors and some of the comorbidities and liver fibrosis vary depending on race and ethnicity. These are my disclosures. And I just want to emphasize the 5 defining cardiometabolic risk factors: obesity, diabetes, hypertension, high triglycerides, low HDL. These are the 5 cardiometabolic risk factors in the MASLD case definition. And a reminder, MASLD is the hepatic component of metabolic syndrome. And this is a systemic disease. So, of course, patient management needs to look to the totality of the metabolic abnormalities that are affecting the patient throughout. And I tend to think of metabolic dysfunction as a kind of stress on the body, and the different organs have different responsibilities in managing the stress. So, of course, the main organs would be the liver, the adipose tissue, but also obviously there are effects that involve the cardiovascular system. So a syndrome is a complex of symptoms and physical findings for which there is no known direct cause. If we have a causative agent, then it's called a disease, not a syndrome. And with that in mind, I want to talk about how associations between risk factors and all-cause mortality, cardiovascular related mortality, and liver fibrosis vary between racial and ethnic groups. How I do want to talk about some of the genomics, so how common genetic polymorphisms that differ between groups alter the relationship between these cardiometabolic risk factors and health outcomes. And finally, it's been mentioned by a number of the previous speakers, we're becoming increasingly aware of the importance of environmental exposures as drivers of liver disease. And we're particularly interested in how environmental exposures can contribute to liver damage and impact MASLD fibrosis, with a particular focus on African Americans. So beginning with diabetes, this is a very important risk factor for cardiovascular disease and all-cause mortality, but I want to show you data that the association between diabetes and fibrosis, which, as we've heard from previous speakers, it's really fibrosis that is the main prognostic indicator of outcomes, liver-related outcomes in patients with NAFLD, and the relationship between diabetes and fibrosis very strongly by race. I want to begin going through some really beautiful work from Korea that examines the relationship between type 2 diabetes and cardiovascular risk in patients with MASLD. This was before the nomenclature change. This is national data with long follow-up of over 10 million people. The investigators divided the group into patients with diabetes. If they didn't have diabetes, they could go into the overweight category. If they lacked diabetes and they were not overweight, but they still had fatty liver disease, they were put into the lean category. What they found was that the presence of type 2 diabetes increased the risk of a cardiovascular event more than fourfold. So very strong association, which is highlighted again in this slide with the diabetes here in red with very strong increased risk of cardiovascular outcomes. Obesity, not so much, and kind of an intermediate value for patients with lean MASLD, which I think Dr. Benzel may be speaking about later today. And looking at outcomes beyond cardiovascular disease in these different categories of MASLD, the patients who had MASLD and type 2 diabetes had a very strong increased risk of liver cancer, and patients with either MASLD fibrosis or in the MASLD lean category, compared to patients with just MASLD and overweight, had a strongly increased risk of all-cause mortality. So the systemic associations between the cardiometabolic risk factors that define MASLD have different relationships with comorbid conditions and all-cause mortality. And one theme that emerged from this study was evidence that in this lean category of patients with MASLD, there was suggestion that there was underreported alcohol consumption. And I think this is an important thing to keep track of, especially as we go forward with clinical trials, to introduce objective measures for alcohol consumption. So as Dr. Ranella mentioned, there is going to be a new category of MASLD with increased alcohol consumption. And I think to properly categorize patients and determine the impact of alcohol consumption, we do need to be using PEth and other objective measures of alcohol exposure. So this shows a study that was done by my PhD student, my wizard, Ning Ma. She took the new case definition of MASLD and applied it to data from the National Health and Nutrition Evaluation Survey, which gives national data. And she was particularly looking for risk factors that are associated with MASLD fibrosis with stratification by race and ethnicity. This is an outline of the analysis that she did, showing in particular that both steatosis and fibrosis in this study were defined by FibroScan or transient elastography. What I'm showing here is that the relationship between diabetes and fibrosis in patients with MASLD varied enormously by race, so that for Caucasians, the presence of diabetes increased the odds ratio for fibrosis over threefold, but it actually had no relationship to fibrosis whatsoever in African Americans. And this was also true of hypertension, which had an odds ratio almost 2 for fibrosis in the case of Caucasians, but had no statistical association with fibrosis whatsoever in African Americans. So one thing I would like to drive home, you can see that in the total US population, the results obviously tend to track with the results for the non-Hispanic white population, because this is just the largest segment of the population. And so you really need to drill down into the data to tease out what is going on with smaller populations. And fortunately, NHANES is a very large national data set, which oversampled minority populations and really allows both Hispanics and African Americans to be analyzed separately. This slide just points out that in previous work, it was already clear that in African Americans, this is a study that used biopsies to define fibrosis and steatosis. For African Americans, there was simply no connection between diabetes and fibrosis. In fact, the odds ratio is less than 1 versus 2.6 in Caucasians. So I don't want to leave anyone with the impression that diabetes can be ignored in African Americans. Diabetes actually is one of the causes of death that has the greatest increase in African Americans compared to Caucasians. So it's a very serious mortality risk factor, but it is not associated with liver fibrosis in patients with MASLD. So I just want to summarize the health outcomes associated with the individual components of metabolic syndrome vary by race and ethnicity. And to really care for the whole patient, it's important to consider how you're going to be addressing these cardiometabolic risk factors, because they are often the major drivers of ill health. So I now want to turn some attention specifically to liver steatosis. I previously showed that there is a strong connection in patients with fatty liver and cardiovascular disease if they have diabetes. That does not seem to be true for liver steatosis, as shown in this recent study that came out in hepatology from Michelle Long's group, where they combined multiple data sets, and what they found was that if you adjust for other variables, liver steatosis was not significantly associated with either new onset cardiovascular disease or all-cause mortality or cancer. So moving from steatosis specifically to obesity, I would like to go over information showing that the health outcomes that are associated with obesity vary dramatically by populations. And again, I think that our concept of what these metabolic risk factors mean for the patient's overall health have been largely shaped by information in the United States from the Caucasian population. And some of our understanding about the associations between cardiometabolic risk factors and major health outcomes may be different in minority populations. So this has been recognized for a while, and it's been discussed as the obesity paradox in the case of African Americans, where it's known that Blacks have less visceral adipose tissue, which is really the type of adipose tissue that is associated with adverse health outcomes. So they have less visceral adipose tissue. They have, on average, lower serum triglycerides and higher HDL. So a good-looking cardiovascular lipid profile. But then on the other hand, they have a higher prevalence of diabetes and hypertension. The relationship between obesity and all-cause mortality is shown here, with dramatic difference between, for example, white men, where there's a strong association between BMI and increased mortality, and African American men, where there really is, it's a very flat line. And the same is true of African American versus Caucasian women. So obesity has little, if any, association with mortality in African Americans, although it's a strong mortality risk factor in whites. So in drilling down a bit, studies have examined associations between obesity and insulin resistance on the one hand, and liver steatosis and triglycerides. And it turns out that these associations vary dramatically between Blacks and whites. So as far as serum triglycerides go, on average, African Americans have lower levels. They have significant insulin resistance, but lower triglycerides and less hepatic steatosis. So this just illustrates the difference in the cardiometabolic profile on average of African Americans compared to Caucasians. So in thinking about what might be the underlying drivers of this pretty dramatic difference in the profile of cardiometabolic setup in African Americans versus Caucasians, I've really been had my attention drawn to basic human genomics and what happened to the human genome as people first migrated out of Africa and were exposed to new stresses of colder weather, different infectious agents, agriculture, and urbanization, which led to a bunch of basic mutations in the germline that I'd like to talk about a little bit. One of the changes that I think is most interesting takes place on chromosome 2, and it's a complex of changes in a block of the chromosome, which collectively cause an increase in a microRNA. It allows individuals to still express lactase as adults, so it allows dairy consumption in adults, and it creates what's been called a thrifty phenotype. So in the presence of these adaptive mutations, individuals are much more likely to store fat than to metabolize fat. And I think that this is a basic metabolic genomic shift in difference between Africans and African Americans, and really all the other populations in the globe. And I just want to present a little bit of information about two well-known polymorphisms that people working in the field of NAFLD will be very familiar with. These are polymorphisms in TMPLA3 and TM6SF2, starting with TM6SF2 first. And I'd like to make the general point that for the SNPs that you may be familiar with that have been associated with more rapid progression to cirrhosis and fibrosis, African Americans generally do not have those mutations. What they have more likely is the ancestral form of the gene. So this is a piece of information about that polymorphism in TM6SF2, illustrating that the original ancestral form of the gene actually protects against NAFLD. This is one of the reasons why there's a lower risk of NAFLD in African Americans, but it actually increases the cardiovascular risk. And the reverse is true of the polymorphism in this gene, which increases liver steatosis and NAFLD and liver fibrosis progression, but it has an offsetting effect that reduces cardiovascular disease. So if you look at the global effect of this mutation and you ask, does this mutation overall increase mortality? The answer is it does not increase mortality, even though it increases liver risk. And something similar is the case for PNPLA3, where the polymorphism that increases liver steatosis decreases cardiovascular risk, and therefore this polymorphism is one of the reasons why there is probably no association between liver steatosis and cardiovascular risk, because it has a beneficial effect on blood lipids. So this is a piece of information from a large study looking at lots of causes of disease, comparing by race, African Americans versus whites and men and women. And it's interesting to see that even though African Americans have perhaps a genomic protection against liver steatosis and fibrosis that's associated with that, they really don't have a decreased overall risk of liver-related death. It's pretty similar. In contrast to a very similar rate of liver-related death between African Americans and Caucasians. African Americans have a very elevated risk of diabetes, which I've tried to emphasize that in some cases this may trace back to genomic differences, and they have a very elevated risk of cardiovascular disease. So we've been curious if they have a genomic protection against the development of steatosis and fibrosis, which we hypothesize, then what accounts for the fact that they have as much liver-related mortality as other people? And of course, there are many risk factors for liver-related mortality that go beyond NAFLD, such as viral hepatitis, alcohol consumption. But we've been particularly interested in toxic exposures as potential drivers of liver disease and liver fibrosis in African Americans, with our thinking driven by the fact that, of course, the liver is the major detoxification site in the body, and as part of performing that role, it becomes exposed to high levels of toxic substances. In the field, I would say that there's increasing awareness that hydrocarbons of many types, as well as heavy metals, are important drivers of liver disease risk. And this is what we found about toxic exposures and liver fibrosis, again, in a study that used NHANES data. And in this case, we were looking at fibrosis with non-invasive marker of the FIB-4 score plus ALT elevation. And again, the study was done by my graduate student named Ma. So one of the important take-home messages is here in this panel, which shows that on average, African Americans compared to Caucasians in the United States, African Americans have higher exposures to essentially the pollutants that we look at. So they have higher blood levels of lead, higher blood levels of cadmium, and higher blood levels of polychlorinated biphenyls. We then looked at the relationship between these pollutants and liver fibrosis. And what we found was that in the case of lead exposure, high lead levels increased the odds of liver fibrosis in African Americans fourfold, but lead exposure actually did not increase the risk of liver fibrosis in Caucasians. So this was a specific example where we found an environmental exposure that was associated with fibrosis, but only in African Americans. So that contrasts with cadmium exposure. I might mention cadmium is a class 1 carcinogen, so definitely something to stay away from if possible. But in the case of cadmium, high blood levels were associated with increased fibrosis, and this did not vary by race. NHANES data set contains relatively a small number of samples in which polychlorinated biphenyls were measured, so we were not able to stratify our analysis by race, but simply had to look at the total population. But what we found was that the people in the NHANES study who had blood levels of polychlorinated biphenyls in the fourth quartile actually had almost a 13-fold increased odds of having advanced liver fibrosis. So I think this just highlights the importance of hydrocarbons and toxic metals and other pollutants as kind of unappreciated drivers of liver disease and liver fibrosis in the population, and then also opens up the possibility that there may be specific susceptibilities in African Americans. So we don't know, but we're certainly curious about the possibility that African Americans have an increased sensitivity to some types of toxic exposures. And some of our thinking about this has been guided by information from the lung cancer field, where it's been known for quite some time that at the same pack years of smoking history, African Americans have much greater lung cancer risk. So at 20 pack years of smoking, an African American on average has the same lung cancer risk as a Caucasian with a 30 pack year history. Just checking. Okay, 5 more minutes. So in summary, the comorbidities associated with MASLD cardiometabolic risk factors vary by race. Diabetes and hypertension are MASLD fibrosis risk factors, are not MASLD fibrosis risk factors in Blacks. So screening for fibrosis in diabetic clinics may disadvantage Blacks because they're not really, the high risk is not going to be overrepresented in the diabetic clinics. So when we design our screening programs, we have to be mindful of the comorbidities that are associated with serious outcomes in MASLD, like fibrosis, and make sure that when we design screening programs, we have them designed so they capture everybody. Blacks are relatively resistant to steatosis in MASLD, but they suffer as serious health consequences from metabolic syndrome as other racial and ethnic groups. So these comorbidities definitely cannot be ignored. They need to be addressed. Genes that are involved in metabolizing food and storing fat have been under intense selection pressure quite recently in the human genome. And of course, it's still a work in progress. We have not quite gotten our genome, so it perfectly aligns with the environment that we're living in. I think clinical trials in MASLD may benefit from stratification based on race and genomic profiles, depending upon what the intervention is and what the intervention is targeting. And finally, that environmental pollutants and other toxins are associated with liver disease and liver fibrosis, and Blacks may be especially susceptible to toxic exposures. So I just have this take-home message that we're just beginning to understand how the individual components of metabolic syndrome impact health and what happens when the components of metabolic syndrome pass through this prism of race and ethnicity and get translated into long-term health consequences. And finally, I want to leave you with this slide, which helps explain why we have put such a focus on African Americans. And it's really because in the United States, African American longevity is about 4 years less than longevity for Caucasians, whereas there's what is called the Latino Hispanic paradox. They actually have the highest life expectancy in the United States. And with that, I would like to thank you for your attention, and very many thanks to my team.
Thank you, Andre. That was absolutely terrific and such an important area that I think has really not had a light shown on it. We have some questions that I think are quite apt. One is, do you have any information about MASLD or cardiovascular outcomes in Native Americans? And also, why are the studies only focused on African Americans and not Hispanics and Asians?
So there is very little information, unfortunately, about Native Americans. I would be very, very interested in expanding to include them, but unfortunately, their population is so small that, at least as far as NHANES is concerned, they're not a large enough population so that we can tease them out. So where they show up is in the other category. And as far as Hispanic and Asians are concerned, in our publications, which I think you all have access to the slides, we do include an analysis of Hispanics, and Asians are in the other category. So in NHANES, the racial groups, when I call them Hispanic, it's really Mexican American, and then other Hispanics plus Asians plus Native Americans in the NHANES data set, they're in the other. So if you go back through the publications that I included from my group, we do include both Mexican Americans and Asians. One of the reasons why I really drill down on African Americans is because I think they've been under ignored. They have this life expectancy gap. And I think I believe they are the most different. And I tried to convey that in my map of Africa. I think it really made a huge difference to have your genome pass through that selection process that occurred when people migrated out of Africa. And so I think, of course, there's a great deal of diversity in non-African populations, but they're more of a set. They're one set with different groups in there: Caucasians, Hispanics, Asians, Native Americans, but they are one set, and African Americans genomically are a second set. That's oversimplified. Obviously, African Americans have admixtures. They're only about 80% African and 20% other. But roughly speaking, I think it's really helpful to recognize this basic genomic difference between something that's primarily an African genome versus what happened after people migrated out. And of course, I think everybody knows we picked up Neanderthal genes, for example. So quite a different genomic structure.
Very quick question and answer related to your last answer, which is diabetes still a risk factor in African Americans for progression to cirrhosis as it is in whites and Latinos?
It does, according to we see no indication that it is a fibrosis progression factor in African Americans. Very surprising, but that's one of the reasons I also included the biopsy data.
I think it's just, this is so important, and we really thank you for this work. It shows how much more heterogeneous the disease is than we think. So anyway, to be continued. We'll move on to our final speaker of the session. I'm delighted to welcome our friend Mazen Noureddin, who is a professor of clinical medicine and medical director at the Houston Liver Institute, has been a leading force in the field for the last 10 years in many areas of MASLD and NASH, including diagnosis and treatment. So Mazen, welcome, and we look forward to your comments.
Good morning, everyone. Dr. Friedman, thank you for the introduction. And I'm privileged to be here today in this great conference and great line of speakers. And I want to say it has been an absolute pleasure in my career to be friends with the Mount Sinai Liver Center, that they continue to be pioneer in liver disease in different aspects. Having Mina and Dr. Friedman as friends has been very rewarding over the years. So my task was to talk about basically the serum biomarkers of liver fibrosis and metabolic health. Those are my disclosures. I help pharmaceutical companies in clinical trial designs, and I've been involved in non-invasive testing development. So multiple talks emphasized on that earlier today. I don't want to repeat it, but I just want to put it back on perspective, the big umbrella and why it's relevant to non-invasive testing and what we're looking for. So you heard about the change in the nomenclature. We decided initially to put it as NAFLD, MASLD for those that they don't know. But I think in the last month in particular, I've been surprised how many people moved to MASLD and MASH. And I think the awareness is increasing, especially between GI and HIP. And maybe we don't need to use NAFLD and NASH, rather just MASLD and MASH. And maybe we can, in the next 6 months, tell the primary care endocrine about this is the transition and then move on. So that's a great progress, great talk by Mauro earlier. And the emphasis here that the disease is very heterogeneous, as Dr. Friedman started his talk earlier today. Start with steatosis, the inflammation, and important for the serum non-invasive and the imaging talks that this group of patients that the MASH and F2 and higher. So we put these two pockets of groups, MASH and F2 and F3 in one pocket, and the MASH and F4, MASH F4 in another pocket. Of course, MASH and F4 is very wide range, including those with compensated cirrhosis, as was alluded in one of the slides that Dr. Friedman presented. But the reason why we have these two, because tons of data focused on the morbidity and mortality in this population in particular. And more importantly, those are the peoples that they're gonna take medications eventually, a pill or injection. And those are the people we're gonna intervene on, and those are the people that we need to identify non-invasively. Why non-invasively? Because the prevalence was shown earlier. We have so many people with MASLD, less in MASH, but still so many that going around and doing liver biopsy will bankrupt the system, will cause side effects and complications, and we really want to move away from that. And those are some of the studies that emphasized earlier. This is meta-analysis that basically talked about the phenomena of increasing morbidity and mortality starting in F2 and higher, more here on the F3 and F4, but there are multiple other publications starting at F2 correlating with morbidity and mortality. Dr. Friedman mentioned the New England Journal paper earlier, which is the only prospective study that looked into outcome that has been going for a couple of decades at least. And what showed here that the F3 and F4 patients have the highest risk of liver complications such as variceal bleeding, ascites, hepatic encephalopathy, and liver cancer. Now, when this paper came out, there were some people questioning if we should only treat the F3 and F4, and the answer is absolutely not. One, because biopsy is inconsistent, and you could have an F2 and they're F3, and you could be missing cirrhotics as F3. And there are data on F2 and higher correlating with morbidity and mortality. So you want to prepare for the exam a bit earlier and start as the F2 and do well in that exam so your patients don't get to F4. So let me talk to you about serum NITs, which will also apply to imaging that Dr. Allen will talk about later. So when we started, I remember in 2012, liver biopsy was recommended in the 2012 guidelines. Liver biopsy was recommended in NASH patients, and I was practicing then. And when I started telling my patients about this, I did not see them coming back. Indeed, the referring GI doctors started referring less because patients went back and complained. And over time, we found that fibrosis matters, and I just showed you the slides why fibrosis matter. And then there was this field of fibrosis biomarkers. As you know, Dr. Friedman was one of the pioneers in this field, and we found out like some serum biomarkers, and this came from the hepatitis C and B field, can predict fibrosis non-invasively. In addition, the elastography phenomena that can measure stiffness technically can also reflect fibrosis. So we're thrilled with that progress, and we started using it as a non-invasive test to detect those, especially with F2 and higher. Over time, though, people wanted more precision, especially when we go for clinical trials. And they said, well, you have this clinical trials, F3, the FDA requires NASH and F2 and higher. So can you show me those? And we moved on to this, what's called the at-risk MASH, which is the MASH and F2 and higher. And those people that are very important to identify and eventually risk stratifies them to start treatment. And I will show you some data in the serum, as well as later Dr. Allen will likely show that the MASH and F2 and higher could be identified with some precision using multiple scores or complex score that you can put together, and it will spits out the results for you. In addition, when you talk about non-invasive testing, well, it's important to tell the patients how they're doing and how severe is their disease. However, at the same time, you want to monitor their over time. So that's another context of use. And there are multiple, but I point out the most important clinically. And one of the most important one clinically is that you want to tell your patient how bad is the disease. And for the regulators, from their standpoint, is what correlates with malo or liver-related events or whatever you want to call it. And this is an absolute must for them to endorse non-invasive testing as a replacement for liver biopsy eventually. It's going to happen. It's just a matter of time. We just have to agree that we all have confidence in the data. So when we started initially in the field, especially in the clinical trial, there were two primary endpoints that were proposed, and those were talked about earlier, which is one, NASH resolution versus fibrosis improvement. If you hit one of those, you get the FDA approval for Subpart H for the drug. And those were thought to be surrogate of outcome. Importantly, when we started this, those were proposed with limited evidence, not that much, and then the evidence came later on. Indeed, NASH resolution still does not have evidence that it predicts outcome. Rather, it's thought to be the engine that drives the process, and it's important to include it as one of the primary endpoint. And where we started, the non-invasive test thought to be a surrogate of a surrogate because they did not correlate directly with outcomes, rather with histology, and that has changed over time. And I will show you later today that the NITs now is a direct surrogate of outcomes. So again, let's talk about fibrosis assessment and at-risk MASH assessment. And since 2021, not that long ago, we started unifying the field in terms of screening the population. Prior to this call of action paper, the society's guidelines actually did not recommend that screening for high-risk population because there were no cost-effective study. Our group did the cost-effective study that adopted the type 2 diabetes as a risk factor that is cost-effective to be screened for. This risk factor, it's it's known to be a risk factor. It's known to have higher prevalence, but we needed that cost-effective studies. Studies from Baylor by Canwall and colleagues showed also the two metabolic risk factors should be screened because they have higher risk for cirrhosis as well as hepatocellular carcinoma. And I don't want to repeat what others saying, but you know the story of screening with FIB4, and then if the FIB4 is in the indeterminate zone, you do a transient elastography, and if it's in between range between 8 and 12, you do further testing. And my task is talk to you about the serum ones. The ASLD guidance came in coordinates with the others, including American Association of Clinical Endocrinology and others. And I actually like the ACE, American Association of Clinical Endocrinology, not because it's different. It's just because many of my endocrine and PCP colleagues will not listen to AGA or ASLD guidelines. They will, but if you bring them the ACE guidelines, they are more prone to listen to you because it's kind of like internal medicine kind of picture. So when I go to them, I actually grab that graph from the ACE guidelines and I show it to them, and I get their ears often. So let me show you what's in the ASLD guidance. And I really like the ASLD guidance that went beyond the AGA, EASL, and ACE and started identifying cutoffs. And those are the cutoffs for F3 on the left and the cutoff for F4 on the right. And it shows you rule in and rule out areas. And I'm going to talk about the serum ones such as FIB4 2.67 and ELF 9.8 for F3ish, and for the F4s 3.48 and 11.3 for prediction of cirrhosis. And ELF really was prognostic one, and I'll talk about that in a second as well. So those are my tasks. I'm going to talk less about others such as APRI and NAFLD fibrosis score because they are fading away, but I'm also going to show you some newcomers in the field that you potentially might see in the future. FIB4, simply, and everyone's talking about it now. It's a formula, age, AST, platelet, and ALT. Go to Google, find what's the score. The Met-Cal has it as well. Less than 1.3, the patient stays with the primary care for the weight loss and exercise. In between, I said to my primary care, well, more than 1.3, something needs to be done, and usually transient elastography or the ELF test as a second step. So there is a serum followed by serum, or serum followed by imaging test as a recommendation by society's guidelines. And again, this is when after the FIB4, you fall in this red box that you need to do either transient elastography or ELF. And this is the ELF score. It's a biomarker of fibrosis, contained multiple components, but it has been FDA approved based on the prognostic value. Again, FDA approved and prognostic value, which is very close to what they're looking for. So more than 9.8 predict progression to cirrhosis, and more than 11.3 predict progression to decompensation or risk of decompensation. So remember these numbers, 9.8 and 11.3. It's available now commercially. I have done it. And the reason why I have done it is because in our liver clinics, it's thought that if you do sequential testing, you're going to narrow down the diagnosis and find where your patient exactly at. So we call it the combo field. The combination of non-invasive biomarkers will lead to the diagnosis and monitoring therapy eventually, and the combination therapy will hopefully get you where to your patient at. And this is the concept of sequential testing. I hear from some people that we made it complicated, but again, you have a liver biopsy you want to get rid of. The regulators still wanting more precision, so we're trying to get that with sequential testing. In addition, in the hepatitis C field, we all learned the RVR in 4 weeks, the SVR12, SVR24. So we learned these mathematical models and sequential testing to predict response. So we can do it here, especially if we're looking at risk MASH patients. So let me go to the back to the ASLD guidance and tell you about the at-risk MASH in particular. And although those are not white serum test is actually a combination between blood and imaging to detect this inflammation in addition to steatosis and fibrosis. So again, at-risk MASH is MASH and F2, MASH and F2 and higher. And here you have the FAST score, MAFib, and MAST, which I'm not going to talk about, leaving them to Dr. Allen later on. But serum-wise, the FAST contain AST, MAST contain AST versus the MAFib contain FIB4 and its component. So this marriage between serum test as well as imaging test is important to increase precision there. Let me tell you what's in the horizon, and I don't mean to complicate it, but FIB4 is an excellent first step that we got into. It is cheap, it's practical, you can auto-populate it in the chart, and I'm aware that Mount Sinai have implemented the FIB4 screening, kudos to them, but also it has some downfalls, including some inaccuracies in age more than 65 with possible adjusting the cutoff and diabetics. So we continue to increase the precision, and I will not be surprised if it gets replaced in the future with other tests. I'm not saying those are the tests. I'm saying like there are other tests that can be used. For instance, a test ProC3 can used as alternative for ALF, and it's a collagen ProC3. It also another fibrosis biomarker. It's promising tool in the field. We use it often in clinical trials. It shows correlation with histological stage and its response to therapy for drugs that are effective. I want to go to machine learning, and this is actually a model that we came up with in a cohort from almost 1,400 patients. And here on the right, I'm going to go to the precision, and why I have it here, because it's all of them are actually serum biomarker in addition to clinical characteristics. So let me show you the performance. To detect F2, our random forest model had AUC of 0.86, better than a FibroScan, F3 of 0.89, better than FibroScan, and F4 of 0.89, better than a FibroScan. So this is very promising. We heard the criticism that 17 variables is too many. I'm not going to sit down and enter them. You're not supposed to do that. The machine should take that and spit it out for you. Now we have actually an abstract presented in ASLD. What we did is we compared just one step of this random forest test, we call it MASLD now, and compared it to the two-step of FIB4 and transient elastography. So again, one test versus two tests, it performed at least similarly the one step to the two steps, if not better in certain areas. Another score, machine learning by Ray Kim's group, called the SAF score, and this to look for NASH and F2 only versus the previous one was F2, F3, F4. Also excellent tool that is being studied out there. Moving on to at-risk MASH. So at-risk MASH, you have two serum biomarkers that you want to watch for that they need further validation, and they started to be validated in NIMBLE and Litmus. So the NIST score complaint UKL40 and microRNA 34A, and it was published in JHEP with curved area and under the curve to detect at-risk MASH. This is our score for disclosure, and many people have been involved here, including the Mount Sinai group. I think Tatiana Kushner is on this publication and many other international. And this metabolomic-based test that looks at multiple lipids as well as other parameters, and it performed better than the FAST score in detecting at-risk MASH. So stay tuned. This is actually CMS approved, and it needs further validation, as I said. Monitoring therapy, I'll start moving quickly here to stay consistent with time. Please let me know if I'm running out of time. So the best study came actually, this is Maru Rinella's publication from the regenerate data showing you that ALT, AST, FIB4, transient elastography ELF go the same direction as histological improvement or histological worsening. But the author also noted smartly that one of them is not enough, and the area under the curve is weak. So that calls for combination of biomarkers to predict also response to therapy. This is resmetirom data showing you that PRO-C3 and ELF drops. This is EFX, efruxifermin data, FGF21 in Nature Medicine, also showing you response to histology correlates nicely with drop in blood biomarkers. And this is the New England Journal paper on the pegozafermin, also showing you the NITs moving in the right direction with histology, including ALT, ALF, PRO-C3, and there are many other examples in New England Journal and others. Let me finish up with focusing on correlation with outcomes. So the serum biomarkers as well imaging do correlate with outcomes in terms, actually they predict, if I want to say it more accurately. So baseline ELF, NAFLD fibrosis score, and FIB4 here predicted clinical outcomes in this large study, 2,000 patients from the Gilead data. FIB4 longitudinally also predicted outcomes in these two landmark study from Hagstrom and colleagues. Finally, ELF was approved based on prognostic data, and I showed you earlier 9.8 and higher correlates with progression to cirrhosis versus 11.3 predict decompensation. So plethora of data out there, and what we think out there, that now we moved from NITs being surrogate of a surrogate to a surrogate of outcomes, which is very exciting. We need more data, I believe, especially the optimistic part of us, which is one of them. I think we have very good amount of data. The people that they are more critical, they want more data out there, and we're happy to deliver that. But importantly, I show you here on the right tons of data from the imaging biomarker correlating with outcomes, and the left some data correlating serum with outcomes. So I think we need to combine them together to reach where we're at. So in conclusion, serum NITs, non-invasive tests, have made a significant progress. We're beyond fibrosis. We're looking actually on the details of histology, and I think we need to forget about it one day if we just can connect them directly to outcomes. Now we're looking at risk match. And imaging NITs have made greater progress, in my opinion. We're waiting for Dr. Allen's talk, and the combination of both can give us a great confidence. And we are working, and we and others are working more data. Thank you very much. Thank you for having me here today.
Comprehensive and scholarly as always, Mazen. Thank you. We have a couple of very relevant questions. One is from Jonathan Patak. Seeing many patients in their 20s and 30s with MASH, what's the utility of FIB4 in patients younger than 34 or 35, and how much of an impact does younger age have on the predictive value of FIB4?
Yeah, there are some data that it's probably less accurate in the age between compared to the age in 35 and 65. I say I usually try to adjust for more age than 65, not for age less than 34 or 35. But I say, let's just follow the guidelines. This is a great start in my mind. FIB4 is to me, it's a PCP test. Teach them these values and go from there. And then it will decrease the number of referral, yet identify the high-risk population that need to come to us.
Great. And if the FIB4 is greater than 1.3, and you had available a follow-up test of ELF or FibroScan, which would you do next?
I would do a transient elastography, not to decrease the importance of ELF. Is just newer to us in clinical practice, and we are still testing it. It's proven to be very good, but transient elastography, as you know, has been around for a decade, and we know its downfalls, and we know it's when it's good. High values sometimes trigger us to do further testing, but low values give us some confidence that we don't have advanced fibrosis.
Okay, great. I just one other quick question. When do you think we're going to get over the hump in terms of FDA approval? What do they need that they don't have? And will insurers pay for any of these?
The insurers will pay eventually. The insurances are interested in moving away from the biopsy and not biopsying that large population. I think the FDA workshop was very informative. I appreciate their open-mindedness to reconsider weak points in the histology. I don't think they will be moving away in the next year or two. We're working with them on generating further data that hopefully multiple consortium such as Litmus Nimble, we're doing a consortium called NALNIT that Nina is part of to get that message across and show the data.
That was great. There's one other question that I think I can handle. Any data on reversibility with lifestyle measures in pre-fibrotic stages? And the answer is probably yes, as long as it's accompanied by weight loss, as well as exercise. A study by
Pilar Gomez.
Yes, Eduardo Vilar Gomez several years ago in gastroenterology showed that the proportion or the amount of weight loss was proportionate to the likelihood of reversing fibrosis, with a 10% weight loss probably necessary to reverse fibrosis. MASLD, thank you very much, and I want to thank all the speakers.
I'd like to welcome our first speaker, who's Alina Allen, an assistant professor of medicine and the director of the NAFLD clinic in the Mayo Clinic in Rochester, Minnesota. So thank you so much, and I look forward to hearing your presentation.
Thank you very much for the invitation and for the honor to speak at this symposium. Great. So I was tasked to review the imaging modalities for diagnosis of MASLD, and because of the 15-minute limit, I will really focus on elastography, which is the main imaging that we use for estimation of fibrosis, but I will also present what other parameters we can detect from elastography. So let's dive right in. With a big principle overview of what elastography means. And this technology uses shear waves that are applied to the liver by a device that varies depending on the technology, and uses the idea that these displacement waves that travel through the liver can be further imaged and their speed calculated, and the speed travels depending on how stiff the liver is. The stiffer the liver, the higher the speed. So it is an indirect marker of fibrosis. I want to bring up to the attention the fact that it doesn't always and only measure fibrosis, because anything else can increase liver stiffness. And these some other processes listed here, which include inflammation, passive congestion, for example, in patients with right heart failure or severe tricuspid regurgitation, portal hypertension, biliary obstruction, or postprandial status, which is the reason these patients have to be assessed after fasting for 3 to 4 hours. There are two main methods to detect shear waves. One method is ultrasound-based technology, and the other one is magnetic resonance elastography. The ultrasound-based technologies are two main ones. There are vibration-controlled transient elastography, or FibroScan, and shear wave elastography, which is essentially acoustic radiation force applied in either one location, this is the point shear wave elastography, or multiple locations, which is the 2D shear wave elastography. This latter technology is integrated in conventional ultrasound systems. MRE is the short non-IV contrast version of an MR imaging of the abdomen. It's a 10-minute exam focused not on evaluation of liver appearance, but specifically on measurement of stiffness, as I mentioned in the previous slide. VCTE or FibroScan and MRE are probably the most commonly used. Ultrasound wave, shear wave elastography is fairly new, so I won't focus too much on the latter, but I'll speak for the rest of the talk on the other two. This slide shows the differences in the ways the shear waves are applied between transient elastography, shear wave elastography, and MRE. And it gives a nice visual about the depth and the volume of the liver where the shear waves travel in each of these methods. The results are displayed in different ways, kilopascals for transient elastography and MRE, and meters per second for ultrasound shear wave elastography. So let's start with FibroScan or VCTE. The waves travel through a cylinder, which is 4 centimeters long and 1 centimeter wide into the liver. And this starts from 25 to 65 millimeters below the skin surface. The volume of the liver assessed is about 100-fold bigger than a biopsy sample. And the limitations because of that space of travel is that central adiposity can affect performance. So the depth of subcutaneous tissue can sometimes come in the way of those waves traveling. So it can fail to measure or lead to unreliable reads in patients who have a lot of subcutaneous tissue. The main advantage of this technology is that it is point of care. It can be used at the bedside, either in the GI or hepatology practice, or even in the primary care or endocrinology practices. We get two numbers on a FibroScan. The one in blue is continuous attenuation parameter, which is an estimation of steatosis. The other one is liver stiffness measurement in orange, which is the estimation of fibrosis. And on this slide, I summarize the main cutoffs used, for example, for CAP for different degrees of steatosis severity and the performance parameters for each of these. And as you can see, this test is very good at identifying any degree of steatosis. The performance and sensitivity or specificity go down a little bit when it tries to differentiate between S2 or S3, which are the advanced, more advanced or moderate stages of steatosis. For liver stiffness measurement, these are the main cutoffs that are used for these specific fibrosis stages. So 8 kilopascals is what is recommended in the guidance to determine those who have clinically significant fibrosis, which means stage 2 or higher, and 13.6 for cirrhosis. And you can see here the performance increases as the advanced fibrosis stage goes to the right. And you can see sensitivity and specificity parameters there too. So performance varies between 0.77 to 0.89 for liver stiffness estimation. MRE uses this larger device to apply shear waves to a larger volume of the liver. The acquisition time is approximately 1 minute. These velocities are transformed into an elastogram where red areas correspond to areas of advanced fibrosis. The volume of liver assessed is about 2,500 times bigger than biopsy. And this is one of the most recent papers, which included several studies with almost 800 patients from 8 international cohorts, which really wanted to assess the performance of identification of stages of fibrosis. And you can see here on the top side, F1, 2, 3, and 4, the cutoffs that are best to identify these stages of fibrosis. Note that the scale here is different than that of FibroScan. 3 or higher is where clinically significant fibrosis occur, whereas it was 8 in FibroScan. And these are the area under the curves for each of these fibrosis stages, varying from 0.82 to 0.94. Important to know that MRE is not confounded by the degree of liver steatosis or by the body mass index. So In a typical liver MRI protocol, we have several phases of several series, but what we essentially need for estimation in MASLD is the amount of fat or sometimes iron content and the actual elastography. So this can be shortened in the 10-minute exam where you one can obtain the exact fat fraction on proton density fat fraction phase of this, or the fat and iron estimation, as well as the stiffness of the liver, which again can mean either fibrosis or a combination of fibrosis and inflammation. The exam time, as I said, is short, and there's a specific CPT code for this shorter MRE, and that's something that I think needs to be known in the primary care space, that we don't need the entire 40-minute exam with a contrast for a full MRE. We can combine these two parameters, which is liver stiffness and PDFF, to assess fat and stiffness of the liver in an automated fashion. And we can also combine these two parameters to assess presence of NASH. This is a snapshot of what we use in our SLD clinic, where we can have the assessment of liver stiffness and of PDFF with the probability of NASH, of NASH listed here at the bottom, including the NAFLD activity score. So you can get a bit more granular information about the disease activity from a study like this. This now seminal study compared the accuracy of, or the concordance, I should say, between FibroScan and MRE in estimating fibrosis based on the patient's BMI. And as you can see, as BMI increases, and it's somewhere around 30 to 35 kilograms per meter square, is where the discordance between FibroScan and MRE starts to increase, with MRE being closer to the truth. So cautious in terms of, for those who have these two technologies available, the use of BMI as a criteria to choose between the two would be important. This is the only study that I'm aware of that compared head-to-head these technologies that I mentioned. So transient elastography is listed here in A, point shear wave elastography, which is the ultrasound-based method in panel B, and MRE in panel C. As you can see that here in the red and orange curves, all three technologies have very high accuracy of identifying stage 3 or 4 fibrosis, or what we would call advanced fibrosis. The performance goes a little down for FibroScan at the earlier stages of disease and trying to differentiate F1 or higher versus F2 or higher. Whereas, for example, for MRE, it stays the same. For point shear wave, a little bit lower in the stage 1 fibrosis or above. There are advantages and disadvantages to all these three technologies. We talked about performance. We talked about the major advantage of transient elastography as being a point of care test, whereas the other two need scheduling in a radiology suite, either in ultrasound or MRI based. There's also a difference in cost for the latter two, being higher than the FibroScan. There's also a difference in the failure rate, a little bit higher on transient elastography because of the limitations I mentioned earlier with the central adiposity, which also affects the precision of measurement. The smaller the percentage here, the more accurate or precise the test is. There's also data on transient elastography and MRE being prognostic biomarkers, as you've seen in an earlier talk. Some little details that I want to also mention about these three tests as we interpret the liver stiffness. There are several confounders that impact the liver stiffness. And as you can see in all of them, things like postprandial state or severe inflammation, such as an acute hepatitis, passive congestion from heart failure or acute biliary obstruction, or other infiltrative processes such as lymphomas or sarcoidosis can artificially increase this liver stiffness, not meaning that patients have fibrosis, but it's yet another process that increases that. For transient elastography and shear wave elastography, things like excessive alcohol intake or steatosis, especially in severe grades, can impact the measurement of liver stiffness. They all have limitations. Obesity is one for transient elastography and shear wave. For MRE, not as much, except for extreme obesity. for patients, for example, who cannot fit in an MRI machine or those who have severe claustrophobia. Ascites affects transient elastography, but not MRE. Narrow intercostal spaces affect those that need that point type of probe, such as transient elastography and shear wave elastography. The advantages we mentioned before for FibroScan, point of care, widely available. It has good reproducibility. For MRE, the high performance for early fibrosis estimation for those situations when we want to see change by one stage over time, or especially for longitudinal assessment, it may be a bit more accurate at identifying subtle changes. It can be implemented on a regular MRI scanner, and it gives an examination of a whole liver, which is a larger volume. The shear wave elastography technologies have the advantage of actual evaluation of the liver morphology, can be used for screening of liver cancer, for example. It gives an assessment of the spleen, so the information of splenomegaly can be complementary to the liver stiffness measurement for evaluation of advanced fibrosis, and it can also be performed in patients who have ascites. They all provide additional information. I mentioned the steatosis by CAP on FibroScan, the steatosis by MRI PDFF on MRE, and also the additional probability of NASH for this technology, and then for ultrasound evaluation of other organs, as I mentioned before. Another technology is iron-corrected T1 mapping, or CT1, which uses the T1 measurement, or T1 relaxation, which is an indicator of water content. So it is a surrogate of inflammation. This is a recent paper that assessed the performance of CT1 in diagnosis of NASH compared to PDFF, or a combination thereof. So you can see here in panel A, it has high performance of NASH diagnosis, similar to that of PDFF. And in panel B, you see the performance at high risk NASH, which means NASH with stage 2 fibrosis or higher. As you can see, the performance is 0.8 for CT1 and higher than PDFF alone. So it has an advantage compared to PDFF alone in identifying some fibrosis degree, which is what the liver stiffness measurement on an MRE can do as well. So the most recent head-to-head comparison of T1 versus liver stiffness in identification of at-risk NASH is a recent study from earlier this year. And in this study, it's confirmed that T1 is higher in performance than PDFF at diagnosis high-risk NASH, but liver stiffness measurement has a substantial improved accuracy in this detection. So important to keep in mind as we screen patients for clinical trials or use this in clinical practice. Other elastography methods combine the technology from imaging, so the liver stiffness estimation, with blood biomarkers. And one of the first ones that did this was the combination of liver stiffness CAP and AST on FibroScan, and this is the FAST score, which was developed to identify at-risk NASH, and the AUC in the original paper was 0.8. Another version of this is the combination of liver stiffness measurement from MRE and the FIB4 score. Both use a specific cutoff, as seen here in the middle panel. The point of this biomarker was to identify patients with stage 2 fibrosis or higher in order to increase the positive predictive value of patients who are included in clinical trials and will need to undergo liver biopsies. The idea is to avoid liver biopsy in those who have a MEFIB index that is lower than the cutoff. Another combination is the MASLD score, which combines the MRE-based parameters, which are liver stiffness measurement, MRI PDFF, and AST. The point of this biomarker is the same as a MEFIB to identify, to increase the positive predictive value of those who may not need a liver biopsy and truly have at-risk NASH or stage 2 or higher. And this is the seminal paper from JHEB by Dr. Nuruddin. So in summary, there are 3 elastography techniques: FibroScan, shear wave elastography, and MRE. They all provide steatosis estimation, by CAP, or assessment of steatosis severity by shear wave elastography, or by the exact percent of fat fraction from MRE. MRE has the highest accuracy, precision, and diagnostic accuracy for distinguishing early stages of fibrosis. It is a version of a short and less costly MRE exam, can provide an automated measurement of LSM and PDFF as well as NASH probability. VCTE or FibroScan has the main advantage of being a point-of-care test and being more widely available. Shear wave elastography provides evaluation of liver and spleen in addition and could be paired with liver cancer surveillance. In patients with obesity or central adiposity, MRE outperforms VCTE and shear wave elastography. And lastly, VCTE and MRE have prognostic value for future liver events, which was presented in an earlier talk. And with this, I thank you and happy to take any questions.
Thank you very much. That was really enlightening. I don't see any questions in the chat, so I have a question for you myself, and that is, could you discuss how these different methods might be able to stratify patients when they have cirrhosis between early and then more advanced cirrhosis? And which of these methods, if any, can be used serially to, for example, monitor for changes in something like portal hypertension?
Great question, Andrea. And the answer is that essentially all provide further information about portal hypertension, but the ones that have most data are FibroScan and MR elastography. So the principle that supports the valid point of all these tests showing more information beyond yes cirrhosis or no cirrhosis is the fact that liver stiffness increases with the severity of cirrhosis. So there are data on FibroScan and MR elastography which show that the higher the liver stiffness, the higher risk of liver events in the future, which speaks to the fact that not all cirrhosis is the same, and there are different flavors. Once you are boxed in that cirrhosis category, there is more information based on liver stiffness that is associated with the patient's risk. And we showed on MRE, for example, the fact that among those with cirrhosis, each increase by 1 kilopascal triples the.
Oh, Dr. Allen, I'm sorry. I think you're frozen. I'm not sure what we can do about
triples the rate of a liver-related event.
There's definitely more information. We don't necessarily use that in our sonography to tell them that yes, you are a much higher risk than a 5 kilopascal if you have an 8 kilopascal, for example. So that would make me monitor that patient more carefully, caution them that there's a higher risk, or even consider surveillance for esophageal varices.
So I want to preview a question. I don't want you to answer it now. Hopefully you could come back and answer it later during our roundtable discussion. And I would like to join this up with a question for Mary Ranella, and that is, what cut points, and I'm specifically thinking of FibroScan cut points, do you think we should be using, broadly speaking, to pick up that patient who has S1 steatosis? So it might be a good question to discuss. I noticed that in the nomenclature discussion, the paper mentions that we don't specify how steatosis is going to be defined, and I think that would be a great question for a panel discussion. And in the meantime, I would like to thank you very much, Dr. Allen, and I apologize. I see that you are an associate professor, so congratulations. I'm sorry that I got your title wrong. And now I would like to turn to Dr. Naim Al-Khoury, who is the Chief Medical Officer and the Director of the Fatty Liver Program at Arizona Liver Health. And he's going to be talking to us about how to get much smarter than we are naturally. So thank you for that.
Thank you for the kind introduction, and I want to thank Mount Sinai and Dr. Bansal for inviting me to speak at this exciting annual event that hopefully will go on for decades to come. And the task that was given to me is to talk about how we can leverage artificial intelligence and new imaging technologies for intelligent augmentation in the field of MASLD and MASH. So these are my objectives. First, I want to describe some of the principles that we utilize in artificial intelligence and machine learning. And then I'm going to discuss the need for AI-powered digital pathology in MASH trials. And I'm going to show you 3 different modalities that are being developed now to hopefully increase consistency with reading the histology slides. And then I'm going to discuss the use of big data and machine learning algorithms to identify at-risk MASH patients and those with advanced fibrosis. So AI is everywhere already. I think our GI colleagues are using it now to increase the detection of polyps. This is becoming part of day-to-day gastroenterology practice. I was visiting with my dentist the other day, and he showed me how they're using AI to identify cavities that could be missed by the dentist. So AI is making an impact in healthcare already. It's here and it's here to stay. And here is a MASH poem written by ChatGPT, another AI tool. You can specify you want it to be written in Dr. Seuss style, and this is what comes out from ChatGPT. I found it very funny, especially the last 2 lines. Too many sweet treats, too much fatty fare had turned this poor liver into quite the nightmare. So, ChatGPT is being used for marketing. Patients are asking questions, and this is going to be something that we utilize moving forward. When we talk about AI, it's important to understand the terminology. So AI is the big umbrella term that we use. Under AI, there is machine learning. This can be supervised or unsupervised. The algorithm is given a task and it learns from the data, and then it improves the accuracy as you feed it more data. And then we have deep learning and what we call deep neural networks, or sometimes convolutional neural networks. This is basically another AI technology that is trying to use the same concepts as the central nervous system, where we have different layers of neurons interacting with each other. In terms of AI applications in hepatology, this was a recent paper we published in CGH, where we identified 4 areas where we think AI may make an impact. First, in imaging and using convolutional neuronal networks to diagnose hepatic steatosis based on ultrasound or CT or MR images. This can be done in a large EMR database. You can also get to quantification of steatosis, not just making the diagnosis. Then the second area is histology. I'm going to spend most of my talk describing different AI-based algorithms to read histology slides, and this will enable us to quantify the NASH or MASH histologic features such as ballooning and inflammation. It may help us also predict response to MASH treatment and maybe identify responses that will not be picked up by the pathologist. And now we're getting to a point where we can get additional data from the biopsy using AI algorithms to predict, for example, the presence of portal hypertension that typically a pathologist will not be able to do. And then the third area is identifying at-risk MASH patients using NITs. We can really screen a large amount of data and a very large sample size very quickly with these machine learning algorithms. And now we also have AI cirrhosis EKG score that can basically, from a typical 12-lead EKG, potentially make a diagnosis of cirrhosis. And then finally, the last area is predicting outcomes. There are several AI-based algorithms that can potentially predict cirrhosis-related mortality, survival after liver transplant, and the risk of liver cancer. So let's get into AI and liver histology. I want to start with this controversial viewpoint. In my mind, in my practice, liver biopsy is dead for the clinical management of MASLD. We really do not need liver biopsy to diagnose the disease, to identify its severity. In the vast majority of patients, I biopsy less than 5% of people I see in clinic, typically when I suspect that there is another underlying etiology. But the problem we face in our research program is that histologic response endpoints are the only endpoints accepted by the FDA now for drug approval, and that's why we do biopsies in our research program. We learned, that the FDA is still very attached to histology at the recent NIT meeting that we had with them earlier in September. And the histologic features that we look at are basically steatosis, and we quantify from 0 to 3, ballooning from 0 to 2, and inflammation from 0 to 3. And these features can be annotated by pathologists, so we can actually teach the ML algorithm how to pick them up. And then we have our fibrosis stage, and this is from 0 to 4. We learned over the last few years that biopsy has multiple issues in the context of clinical trials. This was a trial that we did with the Sirius Therapeutics, the Eminence study, where we recruited 339 patients with biopsies at baseline. They're treated, and then we did biopsies at the end of the trial to assess for response. And what we did here, that we had a single pathologist initially, and we mixed the initial slides and the end of treatment slides and gave them to the same pathologist to read at the end of the trial. And we noticed that the same pathologist was systematically reading the slides at a lower NAFLD activity score and lower fibrosis stage. So we thought maybe we need to have, more experienced pathologists. So we had 2 additional pathologists, pathologist B and C, to reread the slides. And to our surprise at the time, pathologist A, the initial one, when he reread the slides, there was concordance in only 77%. And then when we looked at all the pathologists agreeing, it was only about 50% where they had the same reading. This is another landmark study that was published last year in the Journal of Hepatology by Brunt et al., where they had 9 top-notch experienced pathologists assessing ballooning in 10 slides. And they asked them to score ballooning 0, where you had 0 to 5 ballooned hepatocytes. 1 is between 5 to 50 ballooned hepatocytes, and 2 if you had more than 50. And I'm highlighting slide 2 and 7, where the 10 experienced pathologists sometimes scored the same slide as having only 0 to 5 ballooned hepatocytes, and then another experienced pathologist found more than 50 ballooned hepatocytes. In the figure on the right, you can see also the average size of ballooned hepatocyte picked by different pathologists, and you can see there's a lot of variability in what they consider ballooning. In fact, in that study, they asked the 9 experienced pathologists to circle every ballooned hepatocyte they saw in the slide. And then they wanted to see how many cells they agreed on. And they identified about 1,200 ballooned hepatocytes in total, and they agreed only on 1 ballooned hepatocytes. All 9 pathologists circled that 1 cell that I'm showing you. So obviously, ballooning is very important to define NASH. It's very important for the NASH resolution definition. And if experienced pathologists are struggling, you can imagine what will happen in the real world when we have the drugs, if we need to do histology to assess for response. We also looked at the reliability of biopsy to assess NASH resolution, and you can see the unweighted kappa relatively low. and the same thing also for fibrosis regression. So we do have a problem. We need to increase concordance, and this is where AI can come in. So in terms of developing a machine learning approach to reading histology, initially you need a team, computer scientists, experienced pathologists and hepatologists. You need to digitize the images, and then you need the pathologist to annotate the histologic features that you want the machine learning algorithm to identify. And then you need to develop the model and teach it how to identify these features based on specific features like size, shape, color, texture. And then you would need the machine learning algorithm to be fed some data, start picking these features, and then you try to correct it and use the pathologist to say yes or no, and then the machine learning algorithm will improve over time. Once you develop the machine learning algorithm, you do internal validation, and then you have to take it to an external validation cohort where you feed it unlabeled data and you see how it performs compared to the pathologist. So I'm going to show you some data from 3 different companies very briefly. Path AI is one of the companies that are developing machine learning algorithms. They use what we call H&E stain slides and trichrome staining. So H&E typically for steatosis, inflammation, ballooning. Trichrome is for fibrosis. They use the concept of graph neural network, and they can actually quantify all the main histologic features of MASH and the stage of fibrosis. One thing that they're trying to do is really increase what we can see and make sure we're not missing any of the important histologic features. So an H&E stain slide that you see here can look like this when you use the Path AI technology. You have different colors for steatosis, lobular inflammation, and hepatocyte ballooning. And this reading can be provided to the pathologist also to enhance the accuracy and concordance. But they're also trying to gather data that you wouldn't typically get from pathologists. For example, having a continuous fibrosis score, and that will actually give you more insights in terms of disease progression and regression, because when you only have 4 stages, it becomes a higher bar to show regression from F3 to F2, when a patient could be responding, and you might be missing it if you just have the ordinal outcomes. So this is a slide showing some data with Path AI when it was applied to a clinical trial with resmetirom. They had the central reader, they had a second reader, and then they used the AI algorithm called AIM-NASH in terms of showing improvement by 2 points in the NAFLD activity score or NASH resolution. The AI algorithm was able to actually differentiate between the treatment arm and the placebo arm, and you can see that the results were comparable to the human pathologist. They also applied the algorithm in a cirrhosis trial that looked at using semaglutide, and you can see the response based on pathologist reading and machine learning reading in the placebo arm and the semaglutide arm. And what we learned from this study is that maybe using the AI algorithm will decrease the placebo response rate, which has been a major issue in NASH trials. So you can see here lower placebo response rate in terms of inflammation improvement, steatosis, and ballooning improvement. And finally, the machine learning algorithm is showing some promising data on predicting outcomes. So this is looking at the fibrosis continuous scoring, showing that you can predict progression from F3 to cirrhosis. And then in cirrhotic patients, you can also predict the development of what we call liver related events. Again, not just providing you with readings on the biopsy, but potentially predicting long-term outcomes. The second company I wanted to highlight data from is called HistoIndex. They actually use unstained slides. They expose them to this femtosecond laser, and they look at two concepts called the second harmonic generation, SHG, and then two-photon excitation. And you actually get these signals, and you can have different colors for fibrosis, for example, that you see in the figure on the right. Using this technology is allowing us also to account for changes in steatosis in response to treatment. We know that some of the new NASH drugs are very potent. They can reduce steatosis by 60-65% within 12 to 16 weeks. And there is concern that by reducing steatosis too much, for the human eye, fibrosis can look more dense at the end of the trial, so we need to correct for this. So this is some of the new work that's being done with HistoIndex. What you can see here is the initial slide that shows full tissue. You can see fibrosis and a lime green color, and you can see there's a lot of steatosis, all the black dots that you see, and then you can actually correct for the steatosis area and assess fibrosis after adjusting for steatosis. So their initial fibrosis score is called Q fibrosis, and now we have a steatosis corrected Q fibrosis. And this is an example that was done using resmetirom data. So this is looking at Q fibrosis, the initial fibrosis score, looking at 180 plus parameters of fibrosis, which goes to show you that we can see many more things using these AI algorithms. But using the original Q fibrosis, when they looked at patients that had regression on biopsy, there were changes in 15 features out of the 184, and then in patients that had progression, they noticed changes in 4 features. And then when you apply the steatosis correction, now you can see clear separation between I apologize, this is data with NGM, not resmetirom. They had a drug called aldafermin, but you can see clear separation between the treatment arm in orange and the placebo arm in blue. And now we can see changes in 85 features of fibrosis in patients that had regression. They also developed a new score called the SNAF score for septa, nodule, and fibrosis. So you can develop new scores. One is called Q septa. Second one is called Q nodule, based on the size of the nodules, and then you get your Q fibrosis. And by looking at all these features, you can predict the presence of portal hypertension and varices. And this is what you see in this table. So they showed in this one study that having a SNOF score more than 11.78 had good accuracy for predicting the presence of clinically significant portal hypertension defined by hepatic vein pressure gradient more than 10 based on a transjugular liver biopsy. And then they developed another score called the SNOF-V to predict the presence of varices. And this also had a good accuracy once the score is more than 0.57. So this is, again, the concept of gaining additional data from the biopsy that typically you wouldn't get from the pathologist. And finally, I want to show some data from Biosilvia. They use a different approach. They actually rely heavily on staining. So as I showed you, PathAI, they use standard staining. HistoIndex, they use no staining. Biosilvia, they actually use additional stains, and they look at the whole biopsy. And the advantage here is that you don't need to train the algorithm based on annotation by pathologists. You just need to teach it how to pick up the different stains and what they mean. So they do the classic H&E staining, they do the serious red staining for steatosis and fibrosis, and they do the sonic hedgehog staining for ballooning, and they do other immunohistochemistry assays. And just to show you quickly, this is what they call the morphoquant for fibrosis. So you see the serious red staining on the left, and then you can see what you can get with the algorithm. It can stain the different areas like perisinusoidal versus periportal fibrosis, and they show data that it corresponds well to the fibrosis stage based on the NASH CRN fibrosis score. And then in this slide, we're showing the morphoquant for ballooning. This is the sonic hedgehog staining. And you can see how it stains on the left, and then what you get with the algorithm. Also showing good correlation with the ballooning grade based on the NASH CRM. All right, finally, last few slides, I want to talk about AI and machine learning in identifying at-risk MASH patients. And this is a slide from a paper we published in Hepatology, where we had 1,370 NAFLD patients with biopsy-proven disease. They all had transient elastography and laboratory tests to calculate scores like the FIB-4 index and the NAFLD fibrosis score. And then we used three different techniques of machine learning: logistic regression, random forest, and artificial neural network, to see if we can, scan this database for all the variables that were available to us, and see if we can develop a machine learning algorithm to predict the stage of fibrosis and identify patients with at-risk MASH. And what we showed here is that the random forest algorithm was superior to FIB-4 and FibroScan in picking up significant fibrosis, advanced fibrosis, and cirrhosis. We then focused on identifying at-risk MASH, which is defined as having the NAFLD activity score of 4 or higher and F2 fibrosis or higher. And we compared this to the FAST score that was designed to pick up at-risk MASH, and also the FIB-4 index and NAFLD fibrosis score. And again, we showed that this machine learning algorithm was more accurate, and it does not require the use of the FibroScan machine. So this should increase availability, especially in the primary care and non-specialty settings. So very promising data with this machine learning algorithm. Another algorithm that hopefully you'll hear more about at the ASLD meeting that we're developing with my collaborator, Dr. Winston Dunn at University of Kansas, is called the Aladdin machine learning algorithm. And what I like about this one is you can adjust the settings. So you can say tertiary referral center, where the prevalence of at-risk MASH or advanced fibrosis is, 30% or so. You can do specialty care that's not hepatology care, like GI, where the prevalence is between 10 to 20%. And then you can do primary care, where the prevalence is 10% or less. And obviously, this will affect your positive predictive value and negative predictive value. You can see the variables that you need to calculate the score here. They're readily available: demographic and laboratory data. And then you get a probability of having advanced fibrosis in a specific setting with this algorithm. So this is my take-home message. AI, machine learning, algorithms, and medicines are here to stay, and will definitely change how we practice hepatology, whether it's related to histology interpretation or identifying at-risk patients. I've shown the digital pathology data that's showing promising results in terms of predicting histologic response to treatment, hopefully decreasing the placebo response rate and predicting major adverse liver outcomes. And I do believe that machine learning algorithms will help us mine large databases, help primary care physicians identify at-risk MASH that will need specialty care, and also hopefully in the near future that will benefit from the new NASH therapeutics. So with this, I'm gonna conclude my talk. Thank you again for the opportunity.
That was beautiful work and so beautifully presented and really fascinating. I don't see any questions, and we are running a little bit behind, but Naeem, I hope you will be able to join later for the discussion, because I'm sure people will want to pick your brain about this really fascinating topic. So thank you so much for your presentation. And now I would like to introduce Jamie Chu, here from Mount Sinai. She's the Associate Chief in Pediatric Hepatology, the Medical Director of Pediatric Liver Transplantation, and she's going to be talking to us today about a expanding and increasingly concerning situation of pediatric MASLD and MASH. So Dr. Chu, thank you so much.
Okay, thank you for the invitation to speak here today. I'm going to start with a basic slide of the prevalence of pediatric NAFLD and how this may vary by region and by diagnostic criteria. You can see that in Mexico, the rates of pediatric NAFLD are as high as 42% as diagnosed by ALT. And in the United States, it ranges from about 8% to 13%, depending on using ALT or liver histology. But what I would like to really focus on today is really to kind of focus on the eye of the storm in pediatric MASLD. And the overview of today's talk will be to address whether children have advanced MASH, what factors influence MASH in children, and how do we approach this challenge. So Dr. Alkhoury, who actually just gave a great talk, was the lead author in an article from last year who looked at the NHANES database that Dr. Branch had referred to earlier. This is a longitudinal database, and Dr. Alkhoury and his team looked at young adolescents and young adults ages 15 to 39 who had a FibroScan through the NHANES study. And they eliminated the patients who had excessive alcohol consumption and really focused on the teenagers and young adults that had no excessive alcohol consumption and with a FibroScan CAP score of greater than or equal to 248. And what they found was an astonishingly high number that shows 40% of these children and young adults had NAFLD by CAP scores. And what did these patients look like? So these younger NAFLD patients were male, they had a higher BMI, they were of Hispanic ethnicity, had higher ALT and higher A1C. But what we're really looking at is, are these patients, do they have signs of advanced liver disease? And the answer was yes, that even though 40% of NAFLD patients, 40% of patients had NAFLD, but also 30% of these patients had FibroScan scores of greater than or equal to F2 fibrosis, and 16% of these patients had FibroScan scores that were greater than or equal to F3. So this begs the question of whether pediatric MASLD is potentially a more severe phenotype. And this, why do we think that? So what we know is that even in obese pregnancies, fetuses will have fatty livers. And so there must be some early in utero factors that, Dr. Kushner will talk about in the next talk, but really this setting of obese pregnancy has this milieu that leads to already liver fat in the fetus. And whether these factors are through the mother, as transported through the placenta, and then the fetus sees this, and then the fetal liver has this inflammatory response. So you have this in utero setting, and then additional postnatal events that contributes to worsening steatosis and NASH progression. That includes the breast milk. Dr. Friedman had touched on the microbiome, inflammatory responses, mitochondrial dysfunction, and then you add upon that a Western style diet once these children hit childhood, altered immunity, and then you have this prime setting for NASH and fibrosis. And it was mentioned before, but first-degree relatives of NAFLD patients have a higher risk to develop advanced fibrosis. And so this was a different study that showed that the prevalence of advanced fibrosis in relatives of NAFLD, even without advanced fibrosis, but certainly in patients with NAFLD cirrhosis, had a much higher rate of prevalence of advanced fibrosis than relatives of non-NAFLD controls. Now, these probands had a mean age of 63, and the prime first-degree relative was a mean age of 48. This certainly points to the fact that fibrosis screening should be considered in first-degree relatives of NAFLD. But what I would like to highlight to you today, to my colleagues who primarily see younger adults of childbearing age, it highlights the need to focus on the pediatric NAFLD patient, also as a high-risk first-degree relative. So here at Sinai, we've been approaching this as as a family approach, in that if there is a NAFLD patient that's seen in the adult clinic, specifically, especially with NAFLD cirrhosis or advanced fibrosis, that child should be referred to the pediatric hepatologist, and vice versa. In those patients that we see, children with MASH, we are very cognizant of the fact that we would encourage parents who are very busy, but that they also seek evaluation for themselves. Why do we think that children have potentially this more severe phenotype, and or are genetics and epigenetics more higher risk factors for children with NAFLD? And these factors certainly include epigenetic factors and genetic factors in the progression from NAFLD to fibrosing NASH, specifically in genes that we look at that are higher risk, predisposing to progressive disease, and also protective variants. And what we'll focus on later is the PNPLA3 variant. Our NASH Clinical Research Network, which is a multi-center research consortium, looked specifically at children with biopsy-confirmed NAFLD. And this was a large study that looked at over 800 children. And what they found, similar to what I've already told you, is that they are predominantly male, Hispanic, and a significant proportion of them, 14%, have stage 3 and 4 fibrosis already at a mean age of age 13. And when we look at the PNPLA3, or this risk-conferring gene, this polymorphism GG, they segregated those patients between lower risk polymorphism and the GG genotype. And when you look at those children with GG phenotype and NAFLD, they were younger in age at diagnosis, they were male, they were more likely to be Hispanic, but surprisingly, they actually had a lower weight and a lower BMI and lower triglyceride levels, pointing to the driving force of these polymorphisms. Most significantly, those children that had NAFLD and a GG phenotype had more advanced fibrosis levels based on biopsy. And here you see 16% had stage 3 and almost 2% had stage 4 already at a mean age of 13. One of the Italian groups looked at, can we take all of these factors? Do we take genetics, fetal programming with parental obesity, family conditions, postnatal effects? So all the factors I've just touched briefly upon, let's try and look at these and see what are most significant. So not surprisingly, the PNPLA3 GG polymorphism came up. Parental obesity, like I showed you with maternal obesity, maternal socioeconomic status, breastfeeding status, where not being breastfed was a higher risk factor, dietary fructose intake, and low vitamin D levels. Each one of these by itself will significantly increase the odds ratio, but the predictive algorithm, if you take all of these factors together, predicted that a child would have a 30% chance of fibrosis by age 10 if they met all of these high-risk criteria, which is really sobering for our pediatric hepatology practice, and the fact that we really need to be able to pick up the highest risk children. And it looks like these children not only have progressive disease, but do go on to liver transplant. And Dr. Alkhoury did a study that looked at our UNOS database of liver transplant patients and really looked at liver transplant indications for NASH and cryptogenic cirrhosis, where in the early 2000s, we think that cryptogenic cirrhosis really accounted for undetected NASH cirrhosis. And when you look at that, these pink bars, the number of patients we transplanted in young adults. So these are children and young adults from age 4 to 40. The number of those needing transplant, it has certainly increased. But what is more concerning is that out of the 330 patients transplanted for NASH, again, ages 4 to 40, 100 died with a 30% mortality. And of those that survived, 11% needed to be retransplanted. Now, this 30% mortality and this 89% graft survival are much lower than our normal liver transplant outcomes, pediatric liver transplant outcomes, across every other etiology. So this speaks to the fact that pediatric NASH patients are going to transplant, but that their outcomes are actually worse. So we need to do a better job at really during pediatric stages, picking up these comorbidities that may lead to worsened outcomes. So I just wanted to spend the last section of this talk to talk about the eye of the storm and how this may be specifically relevant to the patient population we see in the Mount Sinai healthcare system and those that are enrolled in our NASH Center of Excellence Biobanking. For our adult colleagues, you may not be familiar with this. This is a growth chart, a pediatric growth chart, and the one that's very typical for the children that we see. So this is a BMI charted from age 2 all the way up to age 9. And you can see this exponential growth of BMI really early in childhood, starting from age 6 all the way to age 9. And this BMI, this child has a BMI of greater than 31, which is greater than the 99th percentile. And in Mount Sinai specifically, this is a map of New York City. And what you see here is the pink circles are the catchment area of Mount Sinai. So we have Mount Sinai that sits right here. And then also we see Mount Sinai, Jackson Heights, one of our satellites in Queens. And what we know is that nearly half of Hispanic youths between ages 6 to 11 are overweight or obese. Hispanic or Latino individuals have had the highest rate of NAFLD, but even specifically, individuals of Mexican origin have one of the highest incidence of NAFLD, and this may be due to a higher incidence of PNPLA3 GG polymorphisms. So I just wanted to show you kind of where our catchment area is, and this Jackson Heights area specifically has a very high Mexican American population. Another group in Mount Sinai, led by Ryan Walker and Ruth Luce, looked at our BioMe data bank, which is a ethnically diverse biobanking initiative at Mount Sinai. And they looked specifically at PNPLA3 GG polymorphisms. And what they found is that if you had a GG, if you were a GG carrier, that you were more likely to get an earlier diagnosis of NAFLD, about 3 years earlier, and that these effects of PNPLA3 GG were most pronounced in Hispanics. But what they did is they did a phenome-wide association study, which is called PheWAS. And this is, in terms, as opposed to GWAS, you take the genotype or the PNPLA3 GG, and then you look at the phenotypes that are significantly associated with that genotype. And what they found was portal hypertension, esophageal bleeding, cirrhosis of the liver, again, variceal bleeding, liver abscesses, all of those phenotypes were significantly associated with carrying that GG phenotype. So we were interested in looking specifically at our pediatric NAFLD population in New York City, given that I showed you that map of the 5 boroughs. And so this study was done by one of our talented senior GI fellows, pediatric GI fellows. And what she did was she took fatty liver disease patients that we've seen in our healthcare system and looked at just the 5 boroughs. Actually, Staten Island had a small number of patients just due to our catchment area, but she looked at 204 patients. And what she was most interested in looking at is whether the prevalence of patients with NAFLD correlated with community deprivation index, another measure of how we could pick up high-risk patients. And so community deprivation index includes insurance status, GED or high school diploma, income, public assistance. And here in the black star, you can see this is where Mount Sinai sits. This is a map of the CDIs of New York City. And these are where the patients with NAFLD landed. And what she found was there was association with the prevalence of NAFLD in patients living in areas of the highest community deprivation index. But when we looked at these patients, what we found is in these 204 patients, the mean age of diagnosis, again, is very young. We diagnosed these patients at age 10. 75% of these patients were Latino with very high BMIs. 49% of them were obese, and almost 30% were severely obese. And this percentage of NAFLD patients was very highly enriched for Latino children, Latino boys, but compared to the 29% of Latinos that live in New York City in general. And when we look at FibroScan data for these patients, meaning are these children having advanced NAFLD, we find that 77% of their FibroScan data showed severe or S3 steatosis, and that 28% had F2 and 10% of them had F3 staged based on kilopascal on their FibroScan. As Dr. Al-Khoury had thought-provokingly mentioned, that biopsy is really kind of, we do not do biopsy very often. So in the few children that we did have biopsy on, which were 19 children, and this certainly has selection bias, we picked up that 37% of our children who had biopsy had stage 3 or 4 fibrosis, which is a very high number. So how do we do this? How is our approach? What are we doing about these progressive disease in children? Our approach to pediatric MASLD really requires multidisciplinary care. The endocrinologist is involved, our local GI doctors, the PCP, pulmonology because of obstructive sleep apnea. We do refer to bariatric surgery consults. The cardiologist is involved for hypertension. But what I want to focus on is the tight collaboration between adult hepatology and pediatric hepatology. Our children have visit in labs every 3 to 6 months. They have a FibroScan every 6 to 12 months, and we often send for the genetics, including obesity and liver-specific genetic panels. Our adult hepatologist Institute for Liver Medicine does all of our FibroScans. There is a family-centered approach specifically to look at those first-degree relationships. And then certainly any adult clinical trials for those 17, 18-year-old teenagers that we see, we will transition them to our adult hepatology colleagues a little bit sooner so that they can be followed by the adult hepatology team and potentially get enrolled in available clinical trials. And of course, our MASH, COE, Center of Excellence Biobank, where we are actively recruiting our MASLD pediatric patients for our biobanking efforts. So really, in summary, I think I would have hoped to show you that children do have advanced MASH, and that genetic, in utero, postnatal, environmental factors all influence MASH in children. This requires a multidisciplinary approach to not only pick up the high-risk patients, and existing challenges really in pediatric MASLD still exist in identifying the natural history of this disease, screening and diagnostics, and also the paucity of clinical trials involved for children. So here I just want to thank the Center of Excellence. This is our pediatric liver team, and I would open it to any questions.
Does the focus on nutrition and other lifestyle interventions, health coaching, fit into that rubric? I think the rubric being the concept of a family-centered approach and a multidisciplinary approach to managing the problem.
Yeah, 100%. It's a great question. And actually, that's what we found is most successful. So children, pediatric NAFLD has a paucity of clinical trials, but actually one of the most exciting clinical trials was one that actually did meal delivery. So when you talk about lifestyle coaching, our group in Atlanta did a thing where they delivered meals with low fructose, and actually that showed positive changes in clinical outcomes. So the idea of lifestyle interventions and having that be family-centered is so important in controlling what kind of food, specifically fructose, goes into the household. So yeah, 100%.
So Dr. Kushner, I see you have a question. Maybe you'd like to enunciate it yourself.
Sure. No, I was just curious about what are your criteria for referring pediatric population for bariatric surgery, because it seems like such a kind of a big intervention, especially in the pediatric age group.
Yeah, so the AAP of the American Academy of Pediatrics does have actually criteria for referring to bariatric surgery. And a lot of that has to do with BMI, but also comorbidities. You know, those patients that have advanced MASH or diabetes and cardiac sleep apnea, things like that, all of that controls. But really, we want to get our bariatric team involved, even just to kind of know them and see how that progresses. So we have been making efforts to, in accordance to the AAP guidelines, to really refer those super high risk patients.
Is there a minimal age?
You know, no, that's how it's, you know, you would be, like I showed you, there's like our average age of really advanced MASH can be anywhere from 10 to 14 even. So it's a really, we're picking them up younger and younger.
So, Dr. Chu, thank you for that presentation and your really groundbreaking work in establishing a program to address this problem. And your work really highlights the importance of the next talk, which is going to be given by Dr. Tatiana Kushner, who is an associate professor of medicine and an associate professor of obstetrics and gynecology and reproductive sciences here. And she is really been trying to set up a liver clinic and OBGYN and primary care as a way of really engaging patients who are coming in for healthcare in consciousness of liver disease. So thank you much, Dr. Kushner, and looking forward to your talk.
Thank you so much. And thank you, Dr. Branch and Dr. Bonsall and Dr. Friedman, really for the honor and the opportunity to present today. And I will be speaking about really maximizing opportunities for engagement by screening and addressing MASLD and MASH in the obstetric population. So I'll go over a little bit about the epidemiology or what we know about MASLD specifically among women. I will also cover some data on how actually having MASLD in pregnancy influences pregnancy outcomes, and then discuss approaches to potentially screening for MASLD in pregnancy and our current recommendations for management of MASLD in pregnant individuals. So to start, I think it's important to recognize that MASLD is quite common in women and particularly in certain subpopulations. In one large meta-analysis, it was found that around 16% of women of childbearing age had MASLD. And among women with polycystic ovarian syndrome or PCOS, 42% of women had MASLD. So almost half of women with PCOS had MASLD. And I think that's an important thing to recognize, because when we see women with PCOS in primary care and in the obstetric setting, we really should be thinking about MASLD and screening in those populations. We also know that PCOS is associated with more severe histologic disease, and that in women with PCOS who are of Hispanic ethnicity, the prevalence of MASLD is up to 70%, so extremely common. There's also recent data among the individuals that are over 50 years of age among diabetes. This was a recent study published by Dr. Ajmera from UCSD that looked specifically in the diabetic patient population over age 50, and actually found that among diabetics over age 50, MASLD was actually more likely to occur in females compared to males, suggesting that even past the reproductive age period, we also need to be thinking about screening for MASLD, particularly women, because they may have higher prevalence. And furthermore, that when they did MR elastography to evaluate for fibrosis, that the odds of advanced fibrosis was higher among females compared to males. Furthermore, there's recent data just published earlier this year that showed that the rise in mortality in individuals with MASLD is increasing at a higher rate in women compared to men. You see that in the figure pictured on the right, which looks at the age associated mortality increase. And we also already have known that MASH is the leading cause for liver transplantation in women. So this already was established back in 2018 that among all indications for liver transplantation, MASH is really the leading cause among women. And so how about MASLD in pregnancy? So these are relatively young individuals who are pregnant. How common is MASLD in pregnant individuals? So there have been some studies, international studies, that have looked in particular on the pregnant population. And you see some of these studies listed here on the table on the left. And what we see is really estimates kind of that really vary depending on the study, where it was conducted, and the methodology. So there are a few large registry-based studies, including one by Hagström from Sweden, which show that among over 1 million individuals who did not have NAFLD, they identified only 110 with NAFLD. Now, obviously, that's not the true prevalence, but actually really just points to the fact that there's really underdiagnosis in terms of diagnosis codes of MASLD in the population. Other studies that have actually screened individuals during pregnancy with ultrasound found much higher rates. So for example, in one case control study looking specifically at high-risk individuals during pregnancy with preeclampsia versus those without preeclampsia, 67% of those with preeclampsia had MASLD compared to 24% who did not have preeclampsia. And then other studies have used non-invasive NITs or blood-based markers to evaluate fatty liver disease in the context of pregnancy. So there was a study from Korea that used a fatty liver index that found that around 5% of individuals during pregnancy had MASLD. We've also learned in the study on the right that when we look at actually advanced liver disease in the context of pregnancy, MASLD is leading the way there. So this is a study by Dr. Sarkar from UCSF that showed that by far, MASLD is the most common cause of cirrhosis in pregnant individuals. So when we think about early advanced disease from any cause of chronic liver disease, MASLD is leading the way. So why should we then think about MASLD in this particular population in pregnancy? Well, it's important to recognize, I think, that pregnancy care is often the only encounter among young women with the healthcare system. Oftentimes, the only time that individuals have health insurance or access healthcare is during pregnancy. And so this really becomes an opportunity for early identification, risk stratification, and linkage to care. Furthermore, identifying MASLD in pregnancy is important because, as we'll see, there are implications of having MASLD during pregnancy on both pregnancy outcomes as well as infant or child health, which we've already heard about from Dr. Chu. So it's important to recognize that MASLD is present in pregnancy in order to appropriately counsel individuals. So what are the implications of MASLD on pregnancy outcomes? So this was a large study conducted using the nationwide inpatient sample by Dr. Sarkar and looked at over 5,000 pregnancies affected by NAFLD or MASLD compared to almost 19 million pregnancies without known MASLD. And in the study, they found that indeed that patients with MASLD in pregnancy were significantly more likely to have gestational diabetes. They were more likely to have hypertensive complications of pregnancy, including gestational hypertension and preeclampsia. They were more likely to have postpartum hemorrhage and even preterm delivery. So that suggests that having MASLD actually increases the risk of adverse pregnancy outcomes. In addition, they saw that over time, there was a significant increase in NAFLD prevalence among pregnancies. And of course, this could indicate a true increase, as we've seen in non-pregnant individuals, but also perhaps increased recognition and screening and testing for MASLD during pregnancy. And we are learning that pregnancy changes can also predispose to the development of MASLD, as well as potentially the progression of disease. And I think this is a really interesting area that there's still a lot more to learn about, but clearly there are changes during pregnancy that can predispose to the development of MASLD or worsening of pre-existing MASLD that include significant weight gain, decrease in insulin sensitivity as pregnancy progresses, and increase as pregnancy is an inflammatory condition, so increased inflammation in the context of pregnancy. And all of these different changes can predispose to really the metabolic pathways that lead to MASLD and MASH. This is a picture that Dr. Chu already shared, and I'll just touch on this, that we also are learning more about how the maternal environment and maternal nutrition can lead to significant outcomes in the infant. So again, identifying MASLD in pregnancy and addressing it can have important implications on infant health. So knowing all this, that we've seen an increase in MASLD in pregnancy, that there are implications on both maternal and fetal and infant health, how can we evaluate for MASLD in the pregnant population? Well, I think we've heard a lot about different non-invasive and imaging tools to evaluate for MASLD in the general population, but the pregnancy care setting is a unique population, and so we really need to have a unique approach to evaluating during pregnancy. And really, ultrasound is the most convenient and most safe imaging assessment tool in pregnancy. Ultrasound is already being commonly done during pregnancy care. And so can we really use that feature in order to assess for MASLD in pregnant individuals? So we have a fatty liver in pregnancy protocol that we initiated back in 2019, where we work closely with our obstetric colleagues to train the obstetric ultrasound techs, who are actually excellent at ultrasound, to during the routine pregnancy ultrasound, the anatomy scan, to actually scan the liver during that time. And then we obtain images, and we have a central radiologist skilled in assessment of steatosis to review these images. And we've also engaged not only the ultrasound techs, but also the obstetric providers to train in a module for assessment of steatosis on ultrasound, which is, of course, much more simple than an assessment of the fetus on ultrasound. And to date, we've assessed over 1,000 pregnant individuals for MASLD. And what we found is that among these individuals who, for the most part, had never even heard about MASLD or NAFLD, 14 prior to coming to pregnancy care, out of them, 14% had steatosis. And among those with higher baseline BMIs, BMI over 25, 18% had steatosis. And if you look at the figure on the right, we also looked at prevalence of steatosis or MASLD among different subcategories. And you see that among the Hispanic individuals with elevated BMI, particularly with BMI over 30, over a quarter of patients had MASLD, so over 25%. And when we looked at our Mexican-American population, those who are Mexican-American with BMI over 30 had a 35% prevalence of MASLD, so quite common in this population. How about other assessment tools? Well, I'll go very quickly through this slide because I think the answer here is clear. Would we ever consider liver biopsy in pregnancy? Well, we've already heard from multiple presentations that liver biopsy is losing favor in general, but just to point your attention to that there has been one study done that has looked at using liver biopsy in the context of pregnancy with very few pregnancies that had liver biopsy compared to over 2 million pregnancies without liver biopsy. And they actually did see some association with an adverse pregnancy course, potentially an association with preterm delivery in those people who underwent liver biopsy. And generally, and not surprisingly, the conclusion of this study was that potential risks, of course, should be weighed against the advantages of having a liver biopsy during pregnancy. So clearly that this will not be something that we will be doing particularly for MASLD and MASH. How about other tools? So transient elastography previously was actually not approved for use in pregnancy, but actually as of March of this year, the FDA lifted that restriction. So the FDA expanded the indication for use of FibroScan and removed the contraindication for pregnancy. So this is quite new and exciting and suggests that this is another tool that we can have available to us that is a bedside tool that can help us with evaluating MASLD. As part of our FLIP protocol, we have been performing FibroScans during third trimester in individuals during pregnancy. And to date, we have performed over 100 FibroScans. And in terms of prevalence of individuals with a CAP score of over 300, suggesting significant steatosis, we found an 11% prevalence of significant steatosis. And when we looked at predictors of steatosis on FibroScan or transient elastography, not surprisingly, we saw an association with Hispanic ethnicity and pre-pregnancy BMI. So those are screening tools available to us. I think to summarize, ultrasound is the most convenient tool, but as we all know, in the prior presentations, there was very little mention of ultrasound because really it's not the most sensitive and specific tool, but hopefully with time we can gather more information about FibroScan as well as other NITs in pregnancy in order to improve our diagnostic ability in pregnancy. So moving on to management. So if you do screen for MASLD or identify someone with MASLD in pregnancy, how do we address this? And I think when we think about pregnancy, it's really relatively three time points that are important. There's the prenatal part where there really is a role for preconceptual counseling before someone becomes pregnant. There's the pregnancy and of course the postpartum time period. And importantly, we do have guidance now both from AASLD, which has been published a few years ago, but also more recently, just this past month, guidance from EASL, the European Society for the Management of Liver Disease in Pregnancy in general. And both of these guidance have sections on what we know about MASLD in pregnancy and how best we can manage MASLD in pregnant individuals. So starting with the prenatal period, what is the recommendation? So in AASLD, in reproductive age patients with MASLD, outside of the context of pregnancy care, it is important to evaluate for symptoms associated with PCOS. So those who have MASLD diagnosis and are reproductive age, it's important to think about PCOS. In addition, they say that preconception counseling should include review of maternal and fetal risks associated with obesity and diabetes and the benefits of optimizing weight and metabolic comorbidities before conception. And so I think it's relevant for our population that we see because we do see many women of reproductive age, and if they are considering pregnancy, we should think about offering preconceptual counseling before pregnancy to optimize their outcomes. EASL similarly states that in women of reproductive age with MASLD, preconception counseling should include a review of maternal and fetal risks associated with being overweight, obese, and or having diabetes. And pre-pregnancy non-invasive screening for liver fibrosis is advised using the most reliable test available. And they also advocate for treatment of metabolic comorbidities for individuals with MASLD before conception. So optimizing metabolic health before conception in order to optimize pregnancy course. And are there specific recommendations for management of MASLD during pregnancy? So per ASLD, really the focus is on optimal gestational weight gain through healthy diet and appropriate exercise. And they specifically cite the Institute of Medicine guidance for healthy weight gain during pregnancy based on baseline pre-pregnancy BMI. And I think we can do this as hepatologists, as GI and primary care providers to know what is a healthy weight gain, to provide that counseling and continue to monitor weight gain during the pregnancy course to make sure that they are staying within those ranges. In terms of monitoring of actual liver tests or liver function, it should be the same as in non-pregnant individuals. The EASL guidelines say that women with known MASLD should be managed as a group with increased risk of gestational diabetes and hypertensive disease in pregnancy with the use of appropriate national screening protocols, including monitoring of tests of liver function. So they state that based on the data that I showed from Dr. Sarkar, as well as other studies, that there is an increased risk of gestational diabetes and hypertensive disease, and therefore appropriate management should occur. And so, for example, that may suggest that those with MASLD should have earlier screening for gestational diabetes because they're at heightened risk. And there may be a role for aspirin, for example, as preventative for preeclampsia, because again, MASLD puts individuals at higher risk of developing this complication. And how about after pregnancy? A key feature here is breastfeeding, and breastfeeding is strongly encouraged. There is data that breastfeeding actually is associated with lower rates of MASLD and MASLD progression, both maternal and in the infant. And so as part of our counseling, we should encourage breastfeeding. And similarly, the EASL guidelines say that breastfeeding is encouraged with women with MASLD. I think another really, really critical part in addressing MASLD, as well as other liver disease and chronic liver disease in pregnant individuals, is really the linkage to care postpartum. Quite frequently, we see individuals during pregnancy, and there's loss to follow up after due to loss of health insurance, as well as other multiple factors. And I think pregnancy, again, is an opportunity to educate individuals and make sure that ongoing care for their liver disease continues after pregnancy as well. So to conclude, MASLD is quite common in women, particularly in certain risk groups, including those with PCOS, and really is the leading cause of advanced liver disease in women of childbearing age, as well as leading cause for liver transplantation. Pregnancy is an important time because pregnancy-associated changes can predispose to MASLD development and progression. And in terms of assessment, ultrasound is the most accessible tool for assessment in pregnancy, but more research is really needed on other methods of assessment. MASLD is associated with adverse pregnancy outcomes and fetal outcomes, and pregnancy is an opportunity to diagnose and stage MASLD and link to care. And in terms of future directions for improving our understanding of MASLD in pregnancy, as I already mentioned, I think it will be important to evaluate other tools for accurate MASLD diagnosing and staging in pregnant individuals. It's not common to include pregnant people in any studies. And so I think it's important to recognize that this is an important population, and we should be evaluating these tools in pregnant individuals as well. And I think we need to learn more about risk prognostication in the context of pregnancy. For example, in some individuals, they may develop MASLD maybe during pregnancy, and it may improve after pregnancy, whereas others may be at really increased risk for progression during pregnancy and postpartum. So we need to understand really which subpopulations are at highest risk. I think it will be important to have more prospective evaluation of the association of MASLD on pregnancy outcomes, postpartum outcomes, and very importantly, impact on fetal health. We need to improve our counseling of women with MASLD in pregnancy. I think the guidelines are really helpful, but still relatively non-specific. And so as we learn more, I think hopefully we'll have more knowledge in order to inform our counseling. Improved understanding of how to modify MASLD associated pregnancy outcome risks. So those with MASLD, what can we do? How can we treat? In addition to weight loss, healthy weight gain that can optimize pregnancy outcomes. And, I think in the possibly quite distant future, really beginning to think about, is there any role for MASLD and MASH therapeutics, perhaps during pregnancy or perhaps during the immediate postpartum period? And I will end there. Thank you so much.
Thank you very much, Dr. Kushner. I don't see any questions. I feel that your talk is such a great segue to Dr. Benzal's talk. So maybe if there are specific questions, I think you've done a great job of showing the landscape of the course that a woman goes through prepartum to postpartum, and we really hope that you'll be able to join for the question and answers. So continuing in the theme of special populations, we're going to have a talk from our leader, Dr. Mina Benzal. She, of course, is the director of the NASH Center of Excellence and a professor of medicine, and she's going to be talking about MASLD and special populations. So thanks, Mina.
Great, thanks. I hope everybody is enjoying this fantastic meeting. I'm going to talk a little bit about factors associated with fibrosis progression rates overall, and then focus on two populations that I think don't get talked about as much, and that's persons with HIV and lean NASH or MASH. So as you've heard many times, liver fibrosis is the single most important predictor of liver-related outcomes. And once you hit stage 2 fibrosis, you have a 10 times increased risk of liver-related mortality. And once you hit stage 3 fibrosis, that goes up to 17 times. And it's really important that to understand that fibrosis is really a dynamic process. On the one hand, you have fibrogenesis, but on the other hand, you have fibrinolysis at the same time. And if fibrogenesis outpaces fibrinolysis, you have progressive scar accumulation, ultimately leading to cirrhosis. So in my mind, I always think of the activated stellate cell pumping out collagen fibrils in response to the most pro-fibrogenic cytokines, TGF-beta1 and CTGF. Now, initially, these are single-stranded collagen fibrils that then get cleaved at their N-terminal peptide, which can be measured, as you heard about earlier, as pro-C3 and P3NP. These individual fibrils then join forces with glycoproteins like hyaluronic acid to form the classic triple helical collagen bundle. That's then gets lysyl oxidase comes in and cross-links that collagen to make it more and more insoluble over time. But at the same time, you have macrophages and other cells secreting matrix metalloproteinases that degrade the collagen. And then there's TIMPs that are inhibitors of those MMPs. C3M is one example. It's an MMP9 mediated degradation product of type 3 collagen. So these fragments and proteins are released into the blood, and ELF score, which you've heard about a few times today, is comprised of P3MP, hyaluronic acid, and TIMP1. So it gives you an idea of what's happening in the liver. Similarly, the ratio of Pro-C3 to C3M can give you an idea of whether fibrosis is outpacing fibrinolysis. It's also important to remember that there are very variable fibrosis progression rates. And while this data is from hepatitis C, the concept holds true for all liver diseases. Most patients will develop cirrhosis over a course of about 30 years. However, there are those who will be rapid fibrosers and develop cirrhosis within 10 years, and there are people who develop cirrhosis. I think we've all probably had patients, for example, with hepatitis C, who may have had a blood transfusion in their teens in the Caribbean on spring break. They're now 80 presenting with hepatitis C because we're doing universal screening, and they don't have any fibrosis. So there are a lot of factors that contribute to fibrosis progression rates. In the case of genetics and NASH, you've heard a lot about PNPLA3, CG polymorphism, increasing fibrosis progression HCC risk in MASLD and ALD, may increase the risk of cirrhosis in Hep C, and increases liver stiffness even in that spectrum of cirrhosis, so ongoing fibrogenesis. On the other hand, HSD17B13 is a loss of function variant that is protective and associated with decreased transaminases, a reduced risk of MASLD, and protection from MASH in individuals with fatty liver. So we're all born with our genetic predisposition. You're either a slow, intermediate, or rapid fibroser. And then there's this complex interplay between concomitant diseases like diabetes, obesity, HIV, etc. There's the impact of social determinants of health. You heard that from Dr. Chu. Where do you live? What do you eat? And then environmental factors, the toxins, cadmium, lead that you're exposed to. Do you drink alcohol? Do you drink black coffee, which is protective? Do you smoke? And so those modulators then dictate your actual disease course. Now, we talked about high prevalence of MASH and NASH and diabetes and obesity, but in HIV, they have an increased risk for MASLD, but more importantly, of those with MASLD, there's an increased risk to have MASH. So I'm going to talk a little bit about the prevalence and risk factors for MASH in patients with HIV, the role of HIV in promoting hepatic inflammation and fibrosis, and what's the therapeutic landscape look like. So when you look at comorbidities among those living with HIV, and these are people who are adequately suppressed on antiretroviral therapy, you can see an increase in kidney disease, COPD, slight diabetes, CVD risk, and liver disease. Now, this does include hepatitis B and C, which we know due to shared routes of transmission is very common in this population. But even if you focus just on MASLD and MASH, you can see that 35% compared to the general population of 25% have MASLD. And again, importantly, 42% have the more progressive form or MASH. Diabetes, hypertension, and dyslipidemia occur at increased prevalence in those with NAFLD and with fibrosis as well, and CKD is also increased in those with fibrosis. Now, the number one cause of death in patients with MASLD or MASH is cardiovascular. And so when you look at 3 prospective cohorts of people living with HIV, you can see that intermediate and high risk cardiovascular risk score, the ACVD risk score, is higher in those with both NAFLD and fibrosis. NAFLD, liver fibrosis, time to HIV diagnosis, and exposure to thymidine analogs or DDI drugs were independently associated with intermediate high CVD risk. In addition, when they looked at 223 patients with HIV in multivariate model, high coronary artery calcium score was associated with increasing age, hypertension, and fatty liver disease. So what about risk of fibrosis progression? Now, this data is from hepatitis C because this is where we have most of the data. We learned early on that those with co-infection develop more rapid progression to cirrhosis compared to HCV monoinfected patients. So the average time to cirrhosis in Hep C monoinfection around 38 years, but that decreases to 26 years in those with co-infection. And associated clinical factors include low CD4 count, alcohol consumption, and older age at Hep C infection. And paired liver biopsy studies demonstrate an increased fibrosis progression rate in those with detectable plasma HIV and moderate to severe necroinflammation on liver biopsy. There are much less data available about fibrosis progression rates in those with MASLD or MASH. In a recent sub-analysis of 24 infected patients where there were paired liver biopsies, 38% progressed in one stage of fibrosis over 12 months, suggesting that there may be more rapid fibrosis progression rates, but small study, we need more to see whether or not that is in fact true. But when you look at clinical predictors of liver fibrosis progression, in addition to diabetes, hypertension, and dyslipidemia, only visceral adipose tissue was associated with an increased risk of fibrosis progression. And for each 25 centimeters square increase in baseline visceral adipose tissue, the odds of fibrosis progression increased by 37%. So to put a pin in this, BMI was not associated with increased fibrosis, but visceral fat was. And Andrea mentioned this as well as other people, that it's really the visceral adipose tissue that carries the increased risk of liver disease. So how do we measure visceral adipose tissue? Of course, there's CT scan at L4, there's DEXA scan, but is there anything in the clinic that we can measure kind of easily? And waist circumference measurements are effective as a surrogate marker for estimating visceral adipose tissue. It should be measured just above the iliac crest, and the waist circumference for men is not increased waist circumference is considered greater than 95 centimeters in men, 94 centimeters in women. That threshold is decreased in Asians down to 90 and 80 respectively. You could look at the waist-hip ratio, and the key is the BMI can be normal. So it's really important not to just be fixated on BMI. So how might HIV promote MASH and fibrosis? And it's really multifactorial in nature. Our group, as well as others, have demonstrated the presence of functional CXCR4 and CCR5 on the hepatic stellate cell, and have demonstrated that both HIV as well as the envelope protein are pro-fibrogenic. Now, keep in mind that in the era of effective antiretroviral therapy, these interactions may be less, and there is still ongoing studies to see at the tissue level whether there are HIV proteins that could still be stimulating this pro-fibrogenic response, but the extent that this is promoting fibrosis in the days of effective antiretroviral therapy is not completely clear. However, what we do know is that early on after HIV infection, there is depletion of CD4 cells in the gut wall. And that promotes increased microbial translocation. The liver is really the gatekeeper. Portal circulation goes to the liver, and the Kupffer cell's job is to clear these translocated products. So in HIV, you have increased microbial translocation. In addition, our group has shown that that Kupffer cells can be infected by HIV, and when they are, even with antiretroviral therapy, they are inherently different, and they have an exaggerated pro-inflammatory response to these translocated products. Others have shown an effect on pro-fibrogenic cytokines, and many have postulated microbial translocation as driving systemic immune activation and aging in HIV patients. So HIV patients are susceptible to NAFLD, ethanol, drug-induced liver injury. Now, HIV then can act as a synergistic cofactor by promoting both liver injury, Kupffer cell activation, and inflammation, has direct effect on adaptive immune response. I mentioned the depletion of intestinal CD4 cells, direct effects on stellate cells, all potentially driving fibrogenesis in this population. So they have an increased number of traditional risk factors, right? They have more comorbidities like diabetes, hypertension, cardiovascular risk. We talked about HIV-related risk factors. Now you superimpose the effect that the drugs that they're on for a long time. Now it's really the early NRTIs that had mitochondrial dysfunction and toxicity, less of a case with the newer agents. PIs and TAF are associated with insulin resistance. TAF causes weight gain, as do the integrase inhibitors, and PIs have been independently associated with significant fibrosis. So there's really a perfect storm in these patients. So how do we screen then and manage them for NAFLD and NASH? So obviously identify high-risk patients. De facto, they're all high risk. Rule out other causes of liver disease, evaluate, and most importantly, fibrosis, and then develop a monitoring and treatment plan. So this will look very similar to what you've seen earlier today. This is an algorithm proposed by the European AIDS Clinical Society, same general concept. You have the obesity, metabolic syndrome, elevation, ALT exposure to D drugs like DDI, and then you want to develop, you want to risk stratify for fibrosis. So less than 1.3, manage in the primary care setting. Consider statin therapy, talk about weight loss. If they're high risk, they go right to hepatology, and in between, same concept, ELF or elastography for further determination. Now, with this high burden of disease, it's a little bit crazy that we have very few studies that have actually looked at treatments for MASH in this population. I won't go through all of them per se. I can just tell you that they were all very, very small studies with very limited results. Tesamorelin, which is a growth hormone releasing hormone analog, which has been shown to restore the pulsatile nature of growth hormone release and decrease visceral adipose tissue in HIV patients, is probably the most promising at this time. In a study of 61 patients, 52 weeks randomized controlled trial, they saw a 37% relative reduction as measured by MR spectroscopy, a 35% reduction in VAT, reduced IGF, which is a pro-fibrogenic signal, and they saw a prevention of fibrosis progression. So not regression, but less progressed. And then Maraviroc is interesting because it is a CCR5 antagonist. As I mentioned earlier, that's a receptor on stellate cells that's pro-fibrogenic. In this retrospective study, they didn't see any effect, but it's, I think, still being studied. So this was a study looking at Maraviroc plus minus metformin. They had 90 patients with NAFLD diagnosed by imaging and biopsy, 30% with abnormal liver enzymes, 19% were on TAF with its concomitant weight gain, and 50% on an integrase inhibitor. Bottom line is that there was no effect, very small study. One of the big caveats is they didn't have a minimum threshold of steatosis needed at baseline. For most of the clinical trials that we do, patients have to have at least like an 8% MRI PDFF. And so it just might have been that the disease, the burden was too low for them to see any kind of signal. The HepMark study is essentially looking at optimized antiretroviral therapy as a backbone, plus minus Maraviroc. This was really just a safety and kind of to see if it's even if patients will stay in the study and their primary outcome therefore was recruitment and retention rates, which was very good. Adherence to BID dosing was very good. And they did look at the secondary outcomes of changes in markers of hepatic fibrosis. And although there were differences in the trend for both ALT and liver stiffness, it's obviously very, very small sample size, but now maybe they will do a larger study here. So the take-home message is patients with HIV have a high burden of MASH due to multiple synergistic effects. You want to try to use metabolic neutral antiretroviral therapy for those at high risk. Avoid PI and early generation NRTIs, which I think is happening. Be aware of the weight gain that comes with the integrase inhibitors and TAF. It can occur at a low BMI, and that is a much more important predictor. Risk stratification for significant fibrosis is still critical. We should be including them as subgroups in more clinical trials. And really, there's no clear DDI concerns for most of the current antiretroviral therapies. GLP-1s can be used in patients with HIV, but those who are on a protease inhibitor, you need to be cautioned because there can be an increase in the RP interval. So what about lean MASH and NASH? Scott mentioned this earlier. An estimated 70 to 20% of individuals with MASLD have lean body habitus. That's defined as a BMI less than 25 in the general population and 23 for Asians. The key is they do have metabolic dysregulation. It's just subclinical. If you did euglycemic clamp testing, you would see it. So they do have insulin resistance even at the normal BMI. Now, importantly, MASLD among lean individuals is associated with increased cardiovascular, liver, and all-cause mortality relative to those without NAFLD. However, there's conflicting data on the severity of disease at presentation, progression rates, liver, cardiac, all-cause mortality, comparing lean versus obese. So there's conflicting data, so we wait to get more information. So general recommendations, as you've heard already, you always want to say, is there another reason for hepatic steatosis in these patients? The high fructose diet, HIV, medications like tamoxifen, congenital abnormalities, endocrine disorders, and toxin exposures. Lean persons with MASLD should be screened for modifiable risk factors like diabetes, dyslipidemia, and hypertension. Risk stratification for liver fibrosis remains absolutely critical. And you heard a lot about the pathway. It's no different in them. And routine screening is not recommended, but should be considered in those with diabetes and age over 40. In terms of the non-invasive assessments that you heard from Mazen earlier, they perform well here in this population as well. And you can see the negative predictive values. Remember, this is more of a rule out approach. You want to make sure you don't miss anybody who has advanced fibrosis, F3, or cirrhosis. So the screening algorithm for lean MASLD, if their enzymes are abnormal, rule out other disease. If their AST and ALT normal, you want to see, is there other cause of steatosis? Now you've diagnosed them with lean MASLD. What's their cardiometabolic profile look like? You want to do aggressive risk modification, assess for fibrosis, and then as Mazen talked about, this concept of identifying at-risk NASH, defined as a NAS score greater than 4 and at least F2 fibrosis. And there are many combo kinds of measures for that. The FAST score you heard about from Dr. Allen, NIS4, MRE, MAST, MEFib, and corrected T1. And then in terms of management, even though they're lean, weight loss still has benefit. And so we do recommend 3 to 5% weight loss, exercise, and reassessment. You can consider vitamin E or pioglitazone. And of course, you want to consider clinical trials in anybody who has advanced fibrosis. So the take-home message here is screen for lean MASLD in patients with diabetes or other cardiometabolic risk factors. risk stratification by determining fibrosis remains critical. And a concept that I hope you get from the course of the day is that looking at one point in time does not tell you the story. So the cross-sectional data is less important as the longitudinal data. You see a patient at a point in time, you don't know where they were yesterday and you don't know where they're going tomorrow unless you do these longitudinal assessments. And it's really that will tell you, are you a rapid fibroser? Are you a slow fibroser, or in between? And so you want to understand the slope of your individual patient. And with that, I will thank you.
Thank you so much, Dr. Benzal, and really thanks to all the speakers who've been in this session. I don't see any immediate questions, but I want to perhaps pass the mic back to you to see if you would like to highlight some of the activities that people might participate in during their lunch break.
Yes, absolutely. So thanks, sorry, we're running a little bit late, but we had a bit of a, we had an extra long lunch break, so I think it'll be fine. I encourage you to go to Novo Nordisk's booth, chat with them, understand, they have a lot of the drugs that are available for weight loss, semaglutide in the form of Ozempic and Wegovy. Certainly they are doing clinical trials, and you'll hear about some of them in the later session. We are doing them here, actually, clinical trials for the use of GLP-1s on NASH. But please go to their booth, chat with them. You'll be enrolled in a raffle for Amazon gift cards, and we will start promptly at 1 p.m.
So thank you so much. Mina, I see that a question has popped up for you, so I'm just going to tell you what it is. Thank you from Amit Bhandari for the general recommendation. I saw you mentioning a high-fat diet as a risk factor. What are your thoughts on refined carbohydrates and hyperinsulinemia? Does fasting insulin levels play any role in risk stratification?
So certainly from a diet recommendation, the more processed, the worse it is. So we always kind of think you want farm to table as much as you can. So fructose, the additives, the corn syrup, that definitely is a risk factor for the development of MASLD. We don't use fasting insulin or HOMA-IR per se that much anymore as a kind of risk stratification, certainly to identify those who have pre-diabetes and insulin resistance. Then of course they're high risk just by that definition, and so you want to do the FIB-4 calculation on them. I'm seeing more people just using the hemoglobin A1C now. If you're in that kind of 5.7 to 6.2 range and you have pre-diabetes, then you're starting to kind of initiate screening for MASLD using the guidelines and the FIB-4, followed by sequential testing with ELF and VCTE.
So thank you so much.